Mm.
Karthik, the link is live.
Yeah, fine. I think we can start. Okay. Good evening, everyone. I welcome you all to Noi Naadi, the Battle of Wits, the first ever TNUC online case presentation competition. I first thank the YOSI President, Dr. Sonal, YOSI Secretary, Dr. Karan, and Joint Secretary, Dr. Nilesh, for giving opportunity to conduct this event. Then I thank my organizing team, Dr. Prasanna, Dr. Pranesh, and Dr. Niranjan, without whom conducting this competition would be impossible. Then I thank my seniors and colleagues who accepted to judge this competition. Then I especially thank Professor Radha Annamalai and Dr. Shreyas and Dr. Sharmila to encouraging their postgraduates to participate in the event. Now I'll hand it over to Dr. Niranjan to introduce the judges and start the session 1.
Thank you, Dr. Karthikeyan. So a warm welcome and good evening to one and all who have joined us on this Tuesday evening. So we have a lot of sessions lined up. So to start off the first session, it is indeed a privilege for me to introduce the judges for the first session. First, we have Dr. Ashwini Kumar Behra, who is the MD and ex-senior resident from RP Center AIMS, who is the founder and the director of Naitrika Super Specialty Eye Care Hospital. And his areas of interest include cataract and pediatric ophthalmology. Next, we have Dr. Neha Mida, who's done her MD from AIMS, DNB, FICO, UK, and MNAMS. She's an ex-senior resident from Dr. RP Center, AIMS, ex-glaucoma fellow from Swiss Glaucoma Research Foundation, and she's currently the director of Avantika Eye Care and Glaucoma Services. Next, we have Dr. Mohammad Ibrahim Asif, consultant cornea and cataract refractive services, I7 Hospital, Lajpat Nagar, New Delhi. So without further ado, let's move on to the session number 1. So as the first participant, we have Dr. Komal Patekar with her case report. Can we have you, Dr. Komal, sharing the screen?
Yes, sir. Yes,
Again, a gentle reminder, we have only 4 minutes for your presentation. Once your screen starts sharing, the timer ticks off.
Good evening, sir. Is my screen visible?
Yes.
Okay. Good evening, everyone. Today I'm going to present an unusual case of late spontaneous reattachment of, of descemet membrane detachment post-DAL. It's not moving. So a 13-year-old male patient came with chief complaints of diminution of vision in both eyes since few months, and past ocular history and his family history was not significant. His uncorrected visual acuity was 636, not improving further in right eye, and finger counting 2 meters, not improving further in left eye. On slit lamp examination, there was corneal thinning and warped striae in right eye, and left eye also showed deep stromal scar along with thinning and warped striae. Rest all of the parameters were within normal limit. So topography scan was done and it showed a severe keratoconus in both the eyes. So as left eye was having severe more keratoconus as compared to right eye, DALK was decided for this patient. So patient underwent DALK under general anesthesia. So big bubble technique was attempted, but it ended up with a large type 2 bubble, which was not intended. During the dissection, small peripheral perforation was also noted towards the end of the surgery. But the procedure was continued as the perforation was small and the periphery. So air bubble was injected into the anterior chamber and dissection was continued up to the Duas layer, and 8.25 mm of trephination was done and donor cornea was sutured to the host. And
12,000 planters monthly over a course of
and small mobile air bubble was ensured.
600 topics which are customized to your weakness.
I request all the other participants to kindly mute, please.
And I read the same.
Yes, so yes, ma'am. Please proceed. You are audible.
This is the day 1 post-op. Slit lamp examination showed graft edema with large DMD from one end of the graft to the other end, and the finding was confirmed with ASOCT. As you can see, the large DMD. So post-op gatifloxacin and predfort was given to this patient, and timolol was started twice a day. Patient was advised desmetopexy, but patient's parents were not willing for resurgery, and considering the risk of general anesthesia, conservative management and observation was decided for this patient. So 2 weeks post-surgery, the edema decreased over a period of time, and there was a little gap between the descemex and the posterior stroma also. So after 1 month of DAL, after conservative management, patient's best-corrected visual acuity improved to 612 with -6 diopter cylinder, and IOP was also 16 millimeters of mercury. And the slit lamp examination showed a drastic decrease in the edema, and the descemet membrane was also completely attached to the host. So coming to the discussion part, DALK is a safe technique for stromal corneal pathology where endothelium is not involved. So if there is a small perforation less than 1 millimeter while doing the DALK, procedure can be continued. But if there is a large perforation during early stage only, it has to be converted to penetrating keratoplasty. If the perforation occurs during the late stage and that too away from the center, DALK can be continued. So if microperforations can occur during the manual dissection, and it can occur during suturing also, and this may lead to early post-operative DMD and double anterior chamber formation. So there are reports also of spontaneous resolution of DM detachment following DAL without a descemet membrane perforation. So there is this case report where a 77-year-old female patient where there was spontaneous reattachment of the descemet membrane after 5 months of DAL after failed desmetopexy. There is one other case report also where there was a spontaneous reattachment of descemet's membrane after a failed air bubble injection. So coming to the conclusion, spontaneous reattachment of DMD can occur in pediatric patient post-DAL even as late as 1 month post-surgery. So conservative management and observation can also be considered if resurgery is not possible. And routine follow-up of this patient is very important to check whether there is a gain of endothelial pump, whether there is a restoration of intercellular complexes and integrity. But for this large case series and appropriate follow-up of the patients is required. Thank you.
Thank you, Dr. Komal. That was well within the time limit. I request the judges to share a few words on the presentation, please.
Hi Komal, this is a nice, interesting case. Okay,
Hello,
and in the first day post-op, when did you see in the graft-toes junction there was not apposition was not good. So you didn't do anything for that, or like you just decided to observe it?
Yes, sir, we didn't do anything as patient was taken under general anesthesia. So we thought we will
okay. So in the post-op,
that much willing, sir.
Okay, in the post-operative period, was there any increase in IOP or anything? What led to what is the cause for spontaneous reattachment? Like, what does literature say, and what is the cause in your case for spontaneous?
Yes, sir. Sir, here there was a micro perforation that was noted. So that led to the formation of double anterior chambers. That may be the cause for descemet's membrane detachment. But over a period of time, the endothelial pump, it starts regaining its activity, and the integrity that develops over a period of time, it causes the fluid to go to detergents, and hence it must have helped for the spontaneous reattachment, sir, in this case.
Yes, excellent. And was there any change in the post-operative management in your case?
So we manage this patient routinely only, sir, like antibiotic steroid combination.
Did you change
no,
the
sir.
medication? No. Okay, fine.
No, sir. Only anti-glaucoma medication and antibiotic steroid combination was started for this patient, sir.
Okay.
Yes, sir. Thanks.
Ashwini, sir, you're on mute. Kindly unmute, please.
What anti-glaucoma did you start?
So timolol was given for this patient, sir.
Okay.
Yes, sir.
Okay.
I think we can move on to the next case, sir. So next up, we have Dr. Gajashri S with her case report. Dr. Gajashri, are you there?
Yes, sir. I'm here.
Yeah, kindly start your screen sharing, please. Yeah, you may start now.
Good evening to one and all present here. I'm here to present a case on corneal ulcer. 47 years old male, driver by occupation, is a resident of Delhi, came with a complaint of diminution of vision, redness, photophobia, discharge and pain in the right eye for 7 days. And the mode of injury was high velocity air with the sand particle, that is a type of tire blast injury. Diminution of vision, which was a sudden and onset, progressive in nature, associated pain and photophobia. And there was a history of redness and mucoid discharge for past 7 days, history of pain in the right eye, which is sudden and onset and progressive over 7 days. And no history of any ocular diseases, no history of contact lens uses, no history of any topical steroid intake. And he has a history of cataract surgery done in 6 years back, which was uneventful. Personal history, family history was insignificant. Systemic examination and general physical examination were within normal limit. Coming to the ocular examination, in the right eye, the visual acuity was hand movement close to face, which is PL positive with PR accurate. Rest could not be done due to the hazy media. And the left eye is 660, which was improving to 69. Near vision color contrast were within normal limit in the left eye. In the right eye, mucoid discharge was present and lid edema was there and diffuse congestion is there. In the left eye were normal. In the right eye, corneal ulcer in the paracentral area about 3 into 2 mm with indistinct margin surrounding infiltrates with thinning. Perilimbal infiltrate over the 360-degree with superficial vascularization, and there is no satellite lesion. Coming to the anterior chamber, it was normal depth, 3 plus cells and 3 plus pair was there. Exudates with mobile hypopyon of about 0.5 mm, left eye with a normal limit. This is a Leibovitz corneal diagram of the right eye showing corneal ulcer, which is in the paracentral area, which is surrounded by a dense infiltrate with superficial neovascularization and hypopyon, and this is the optical section of the same. In the right eye, iris was muddy, dull leisure with fibrinous strands was there, sluggish reaction, and in the distant direct ophthalmoscopy, only the yellowish glow was present. In the left eye, rest everything were normal. This raises a suspicion of endophthalmitis, so we did an ultrasound of the right eye. It showed vitreous exudates. So we came to the conclusion of right eye mixed bacterial and fungal corneal ulcer with exogenous endophthalmitis. So we did an investigation, routine investigation were done, and corneal scraping was sent. NCCT orbit were done to rule out intraocular foreign body. We started the patient on systemic oral antibiotic with intravitreal vancomycin, septamycin. As the fungal was also suspected, we started an amphotericin along with topical antifungal, and atamycin was started. And the first post-op day after an intravitreal injection was given, the vision was finger counting close to base. Ulcer size remained the same, but the perilimbal infiltrates were reduced. AC reaction was reduced, but the fibrinous reaction remains the same. In the dilated fundus examination, we could able to appreciate the disc. The corneal scraping reports showed the growth of Aspergillus fumigatus. And after 48 hours, again, since there was an improvement, we have given one more dose of intravitreal, including antibiotic as well as an amphotericin. And the second, after the second intravitreal injection, patient is symptomatically better. The vision remains the same, but the ulcer size remains the same, but the infiltrates were reduced. AC cells and fibrinous reaction were completely absent without any hypopyon. Pupil were made dilated. On the dilated fundus examination, first order vessels were visible. Presumptive vitreous stap reports reveal a Staphylococcus species. This is the first picture when the patient presented with us with the dense infiltrates present over the nasal area as well as the perilimbal infiltrate with the hypopyon. And the second post after the first intravitreal injection.
We have last 10 seconds, doctor. Kindly hurry up.
And this is a third picture. And the ultrasound examination and the patient presented with is this one. The dense vitreous exudate were there. After that, it was reduced. And I would like to highlight the clinical outcome study in which the 7 years the study
Time's up, doctor. Kindly wind up.
Oh, thank you, sir.
Thank you, Dr. Gajashree. Okay. Judges, please, your opinions.
Yeah, it was a well-managed case. And what was the final outcome of the patient?
Sir, the visual acuity remains the same. It was a finger counting close to face, but the ulcer has reduced and there was no vitreous exudate. The patient has been followed up like every month. The patient is under follow-up.
Okay. So apart from that, fungal, how long did you continue your fungal treatment, and how long does it take for the ulcer to resolve? How long time period it took?
Sir, it was like we have given only the 2 intravitreal injection. But the topical continued for about 3 to 4 weeks.
Okay. Because usually fungal ulcer, fungal keratitis usually takes longer duration than what it is expected. And plus fungal, it is not that common for a fungal keratitis to become a fungal endophthalmitis. Plus, you didn't have a fungal report from vitreous tap, right? There was no fungal.
Mainly, it is a fungal keratitis that lead to an endophthalmitis, but was a bacterial.
No. Why is your diagnosis is fungal keratitis with endophthalmitis? Could it be just fungal with the bacterial? Because you didn't have any vitreous biopsy proving that it is a fungal endophthalmitis, right?
Sir, no, sir, we have sent a vitreous tab that showed a staphylococcal species growth.
Okay. So intravitreal, did you give antifungal also or just antibacterial?
No, sir. At the first, like after the initial examination, we suspected a mixed corneal infection. That's why we started with both antifungal as well as an antibacterial.
No, intravitreal.
Yes, sir. Intravitreal amphotericin along with the septan vaccine.
Okay, fine.
Dear, I don't know if I missed, but was there any systemic predisposition? Did the patient have any systemic illness?
No, ma'am. He was a non-diabetic, non-hypertensive, and there is no ocular surface disease.
Okay. Did you run any blood workup?
Yes, ma'am. Routine investigation were done that way with the normal limits.
Okay.
Thank you, judges. We'll move on to the next presenter, Dr. Himani Jamod. Are you there, ma'am? Dr. Himani?
Yes, I'm here. I'll just start. So I'll share my screen.
Yes, please.
And,
yes, ma'am. Your screen is visible. You may start now.
So a warm good evening to everyone. I would like to thank YOSI for giving this platform. So the case is of an air bubble in the anterior chamber in a patient with primary angle closure suspect. So patient came with a complaint of blurring of vision in left eye with mild headache on left side since 3 days. Visual acuity was 618 and 660 unaided. Conjunctiva and cornea was normal, whereas the right eye pupil was normal, whereas on the left eye it was dilated till 8 mm. Lens was showing some early cataractous changes. Right eye disc was normal. Left eye media was hazy, probably because the anterior chamber was containing air bubble in a shallow AC with a dilated pupil, and air bubble was filling the less than 1/3 of the anterior chamber space. So what we did was we observed the patient for 3 days. We did investigations. After 3 days, the air bubble was absorbed and AC was clear with a regular and reacting pupil. So after the investigation, we concluded it as a PACS case, and we did a YAC-PI in both eyes. So the test we did was applanation tonometer, which was normal, that is 14 and 16 mmHg. Gonioscopy suggestive of occludable angles. OCT of left eye showed a poor signal strength, probably because of hazy media, but grossly there was no treatable lesion. So air bubble in a quiet eye is not common, but the causes in such scenario is not known. It can be seen after cataract, refractive surgery, intravitreal injections, or laser procedures. The long-term effect of air bubble can lead to mid-dilated pupil, corneal endothelial changes, or a rise of intraocular pressure up to 30 mmHg because of pupillary block or because of angle closure. The causes of unilateral mydriasis are many, like benign episodic unilateral mydriasis, and the life-threatening cause can be carotid artery diseases. So in my case, no significant cause came out for the presence of air bubble, but unilateral mydriasis can be because of benign episodic unilateral mydriasis. It's a condition where there is a sudden onset of mydriasis in one eye with headache and eye pain. It is an isolated cause of pupillary asymmetry. Its pathophysiology is not clear. It can be because of sympathetic hyperactivity of the iris. So it is characterized as a reversible condition. It can be seen with or without headache mostly in females, associated with migraine. It is usually unilateral and it resolves within hours to days. Ketty et al. Have documented and various case reports on BEUM, and she has revealed that it might take mydriasis to resolve within hours to days or months or years. So I would like to conclude that air bubble in the anterior chamber without any ocular procedure is rare. It can be an idiopathic condition or because of some non-documented cause. In our case, the time was given to assess the condition as IOP was not raised and complication was not visible. Laser peripheral iridotomy was done because it's an angle closure disease, and so that to rule out any retinopathy. The limitation of what we didn't do was that we didn't go for MRI, CT scan, or Doppler, and the resolution duration for mydriasis and air bubble have not been monitored closely. I would like to conclude that air bubble commonly observed after surgery only, so detailed history is much. We have to look for the side effects like rise in intraocular pressure. BEUM is rare. We should be aware of this condition. And unilateral mydriasis may help in ruling out the life-threatening diseases. Thank you.
Thank you, Dr. Himani. That was well within the time limit. Judges, your comments, please.
Dr. Himani, you have written in gonioscopy about occludable angles. So only occludable angles were present, or were there any goniosynicae, any blotchy pigments?
No. It was occludable only. No, any intermittent pass was also not there, like no any other significant. And in fact, when air bubble was present, we was not able to perform the gonioscopy because it was present with air bubble as well as like dilated pupil. So we waited for 3 days, and when the air bubble and mydriasis went off, then only we did gonioscopy.
Okay, what was the pupil size in the eye that had mydriasis?
It was 8 mm. It was like we have like how we do pharmacologically dilating, how we do. It was like that.
Okay. Although you could have performed gonioscopy in the fellow eye on that day, even if it was there in the one eye, you could have. It will give you some insight on that day itself. And also, you mentioned that the OCT signal was poor. Why?
Because of the presence, when the air bubble was present, we performed the OCT. So we thought the media was like all blackout, maybe probably because of the presence of air bubble.
I'm sorry, the air bubble was very small, right?
Yeah, I know it was very small, but it was very difficult to have an OCT.
Was the cornea hazy? Was there a cataract?
No. Cornea was clear. Cataract was there, but only the cortical cataract was there.
So there is no reason that why the signal strength was poor. I mean, you could not determine a reason for that.
Yeah. But we could have we had seen the macular integrity. It seems to be normal, like what we saw. And then after like YACTI I have performed, we did dilated ophthalmoscopy. The fundus was normal.
Okay. Last question. Did the patient have loss of accommodation also, or it was only mydriasis?
We didn't go to check for the accommodation, but mydriasis was definitely there.
Okay, did you do refraction for the patient? Like you had vision, the visual acuity was less. Was it improving with pinhole, not improving with pinhole?
No. We didn't do that.
Thank you.
Thank you, ma'am.
One more question for Himani. I mean, did you check for RAPD? Was it like reactive both sides, or there was RAPD associated?
Once the air bubble and the mydriasis went off, we did the RL. The pupil was reacting normal to light, both the eyes.
Okay.
Actually, till date, I don't know why that air bubble was present. So I was hoping like you guys can give me some insight on that.
No, this is quite rare, and it is something, it is a little strange. I mean, like any decompression in the anterior chamber can produce air bubble from the vessels, from the angle vessels and all. But all these can be some proposed theory. We will not be able to give a proper reason for that.
Okay.
Thank you, judges. Next up, we have Dr. Rahima. Dr. Rahima AN.
Yes, sir.
Yeah, could you please start your screen sharing?
Sir. Sir, is my screen visible?
Could you go full screen, please? Yeah, you may start now.
Yes, sir. Good evening. My topic for today is case presentation is comparison between the fornix-based versus limbus-based flap in trabeculectomy performed for the case of juvenile open-angle glaucoma in a 11-year follow-up. The chief complaints were 11-year-old boy, resident of Orissa, presented with a complaint of phobia since 1 year. On elaboration, he also told that he consulted a local ophthalmologist and he was told to have allergic conjunctivitis in both eyes. He was treated with topical steroids and he was told to have record high IOP and he was started on anti-glaucoma medication. Past history, family history and history of systemic illness, allergic history was not significant. Best corrected visual acuity in the right eye was 6/9 in N6 and left eye was 6/6 in N6 with spherical correction of -6.5 in the right eye and -4.5 in the left eye. And general system examination was normal, and an external examination, pupil were mid-dilated pupil in both the eyes and sluggishly reacting to light, and RAPD was present in both the eyes. Slit lamp examination and showed the cornea had a superficial punctate keratitis, and anterior chamber was quiet and it was Van Herrick grade 4, and Goldman applanation tonometry was 42, record 42 millimeter of mercury pressure in the right eye, and the left eye was 41 in all the quadrants in both eyes. Cup disc ratio 0.9, and both eyes show the cup disc ratio of 0.9 and the bipolar thinning, and RNFL defect was present diffusely in both eyes, and rest of the fundus examination was normal. The patient was diagnosed to have a juvenile open-angle glaucoma, which was worsened by a steroid response. It was pachymetry in the right eye and the left eye was 555 microns, and HVF 30-2 and 24-2 showed advanced tubular field loss. And patient was started on lubricants, and he was given oral acetazolamide 3 times a day along with syrup potassium chloride, and topical anti-glaucoma medication was started. The IOP was not adequately controlled. Patient underwent trabeculectomy in the right eye with mitomycin, and fornix-based trabeculectomy was performed in the right eye, and limbus-based trabeculectomy was performed in the left eye. And this is a slit lamp photograph of the right eye having done the fornix-based conjunctival flap and left eye limbus-based conjunctival flap. And as we could see, we could see diffused avascular and flap in the right eye. In the left eye, it is localized flap, and it is thin, cystic and avascular, and tide progression analysis showed a minimal progression. And though the Moorfield safe surgery principle was applied in both the surgeries, we could see that the fornix-based flap was more diffuse, elevated and avascular, whereas in fornix limbal-based flap, we could get a cystic and a thin localized flap. And in this case discussion, I would like to mention that in the specific case, we were able to differentiate between the flap in the same patient. In like over 11-year follow-up, we were able to describe the blood morphology, and also
Last
we were
10 seconds, doctor.
Yeah, we were able to see the how much the IOP control was there. So it was all adequate. Thank you.
Thank you, Dr. Rahima. I request the judges to give your opinions, please.
It was well presented. You could have added this photographs also while presenting a glaucoma case. It would have been nice. And also, could you tell me that what was the strength of mitomycin used here?
So, ma'am, 40 milligrams.
Sorry?
So, ma'am, 40 mg per ml, ma'am.
40.
0.4. Sorry, ma'am. 0.4.
0.4 what?
Percent.
Sorry, you're not audible, Rahima.
Hello?
Yeah. I was asking what was the strength of mitomycin used in both your cases, in limbal based
Yes,
and
0.4 mg per ml, ma'am.
0.4 mg per ml. And for how much duration?
Ma'am, for 1 minute, ma'am.
Okay, in both the in both the modalities?
Yes, ma'am. The surgeon and the patient.
Hello. Okay.
Hello.
Any other comments, judges?
No, we can proceed to the next case. I think she's not
Okay.
audible. We can.
Yeah. Thank you, judges.
Yeah.
So after this, next up, we have Dr. Priyanka R. Dr. Priyanka? Yes, she's
Yes, sir,
online.
I'll be sharing my slide.
I think the
Dr. Rahima, could you please stop sharing your screen? Dr. Rahima? Yeah, thank you.
Dr. Niranjan, I think we left Dr. Komal Pateke's second case, I think.
Oh, yes, sir. Dr. Komal, shall we do it after this one, sir? That's okay.
Yeah, after this one.
Yeah.
So can I start, sir?
Yeah, you can start.
I'm Priyanka. I'm presenting a case on severe vitritis. It's a rare representation of subliminal transclear cyclophotocoagulation. So coming to the case details, 42-year-old female was a diagnosed case of glaucoma, pigmented glaucoma in 2021. And when she came for a regular follow-up, she was already on topical anti-glaucoma medications. And she doesn't have any systemic comorbidities. So when she came for the first time in Jan 21 for the routine checkup, her vision was 6/6 and her IOP was incidentally found out to be high in both the eyes. And gonioscopy showed open angles with the hyperpigmented trabecular meshwork. And there was cupping of 0.8 in the right eye and 0.4 in the left eye. So we started on anti-glaucoma medications. 3 months later, when she came for follow-up, her IOP was still high in the right eye. And both the eyes, she was continuing anti-glaucoma medications. So we went ahead with trabeculectomy and augmentation with mitomycin C in the right eye. 1 year later, IOP was still high, was controlled with anti-glaucoma medications in the left eye, but right eye was completely fine. So we planned for subcyclophotocoagulation in the right eye. So first postoperative day, her visual acuity was 6/6 in the left eye, and IOP was still high, and anterior posterior segment was within normal limits. 1 week postoperatively, her vision was 6/6, and IOP was controlled only on 3 anti-glaucoma medications. And 3 weeks later, she came with a sudden onset diminution of vision in the left eye, and vision was hand movements close to face, and IOP was controlled only on anti-glaucoma medications. And there was found to be, she was having retrolental cells and grade 4 vitritis. This is a slit-up examination of the left eye. The first picture showing the diffuse illumination, and the second picture showing focal illumination with focal width showing Krukenberg spindle. This is a dilated fundus, right eye showing 0.8 cupping, and left eye showing grade 4 vitritis with a disc hazily seen. So B-scan was done on the very first day, showing multiple dot-like vitreous echoes suggestive of vitritis. So we started on pulse dose of intravenous methylprednisolone of 1 milligram per kg for 3 days, and along with the topical prednisolone, which was continuing on 3 topical anti-glaucoma medications. So 1 week later, of following oral steroids, vision was completely improving to 6/24, and AC was quiet, and vitritis was improving gradually. So 3 weeks later, our vision came to be 6/6, and our IOP was controlled. So slowly we stopped our steroids over 2 months. So our fundus was, some problem with my PPT. So our fundus was completely resolved, and vision was regained back to 6/6. So subcyclophotocoagulation, we used this machine called Vitra Quantal 810, where we use G probe and we use sweeping movements in the anterior and posterior 3 millimeter away from the limbus, where we spare the 3 and 9 o'clock position to prevent the ciliary neovascular structures. So this delivers an infrared diode laser of 810 nanometers. So this mechanism of action is that we deliver a short pulses of repetitive energy instead of a continuous mode where we use in DLCP, so that the collateral damage is avoided and vision won't be impaired. So the take-home message is that subliminal transclear cyclophotocoagulation is a popular choice in the treatment of refractive glaucoma, and as it reduces IOP significantly and patients can be medication-free, but it causes rarely a sight-threatening.
Time's up, doctor.
Thank you, sir.
Thank you, doctor. I request the judges to give their comments, please.
Dear, can you please tell me what were the settings you have kept while doing the subcyclo?
Subcyclo, we use duty cycle of 31.3%, along with 0.5 on time and 1.1 off time, so that laser doesn't work in off time.
Can you change these settings? Can you change the duty cycle?
No, ma'am, we can't. Subliminal is a separate entity where we use 31.3% for all.
Okay. Now come next. What other settings? That is a fixed parameter. No, you cannot change that. I'm asking you, what settings did you use?
The on and off period also is same only. With power alone, it will change.
Yes. How much power did you keep? That's what I'm asking.
80 milliwatt.
How much?
80.
Okay.
80
and how much duration, how much degree you had treated? 180, 360, 270?
180 degrees superior and inferior, leaving the 3 and 9 o'clock position.
Okay. And how much time was spent on the superior 180 degree?
80 seconds will be given to the laser by doing a sweeping motion.
Okay. 80 seconds for one quadrant or one hemisphere?
For one hemisphere.
Okay. All right. And how many sweeps were made in 80 seconds?
2 to 3 sweeps will be made.
2 to 3 sweeps. Okay. Okay. All right.
So I want to ask you, what is the baseline IOP of that patient? The patient's average?
When she came first, it was 32 and 28. We started an anti-glaucoma medication. After that, still it was 18 on 3 to 4. First it was 4 anti-glaucoma medications. Then after that, it reduced to 3.
Reduced to?
3.
IOP 3.
3 anti-glaucoma medications.
Okay.
IOP was 3.
Okay. So what is the copying? What is the copying of the patient? I missed it.
Alright. The eye which we did was cupping was 0.5. The other eye had 0.8.
Okay. Because this cyclo, in my opinion, is it can be used, but in case of advanced glaucoma where patient is one-eyed or non-eyed, it is better to avoid. It is an intermediary choice between glaucoma medication and invasive surgeries. Still, there is a reported vision. It is a temporary measure because after that, after 2 or 3 months, the IOP is bound to rise. If you follow up the patient, the IOP will rise for sure. So if you are copying with 0.9 near-term copying, we should avoid and go for invasive surgery in one-eyed patients. That is my personal opinion. So good, keep it up.
Thank you, judges. I request Dr. Priyanka to stop screen sharing, please. Next up, I request Dr. Komal Patekar to present her second case for the day.
She's 5th in the list, right? 5th.
Yes, sir.
I think we have.
Yes, doctor, you may start.
Yeah, good evening, everyone. Today I'm going to present an unusual case of sequential corneal perforation in pellucid marginal degeneration. It's not moving. 1 minute, sir. So a 64-year-old male came with complaints of painless progressive diminution of vision in right eye since 1 month. There was no history of any ocular surgery or trauma or medication in the past. On his uncorrected visual acuity was finger counting 3 meters, improving to 618 with correction. And slit lamp examination showed crescentic arcuate reflex 2 millimeter away from inferior limbus from 4 o'clock to 8 o'clock position, and other eye was normal. So corneal topography was advised for this patient, and other blood tests were done to rule out the collagen vascular diseases. So this is the picture that is showing a classic crack flow appearance with against the rule astigmatism in this patient, and left eye was within normal limit. So the diagnosis of advanced pellucid marginal degeneration was made, and patient was advised scleral contact lenses, but patient didn't opt for it, and patient opted glasses. So after a period of 4 months, patient came with pain and diminution of vision in the same eye, and full thickness corneal perforation with iris prolapse was noted. So this patient underwent 2 primary sutures with surrounding compression sutures and iris repositioning, and post-operatively antibiotic cycloplegics were started. 1 month post-op, vision improved to 6/9 with correction. After this surgery, the against the rule astigmatism and keratometric value decreased over a period of time. Over a period of 4 years, patient now came with a diminution of vision, which was gradual in both the eyes, and patient was diagnosed with cataract in both the eyes. So patient underwent superior temporal clear corneal phacoemulsification with customized toric IOL in both the eyes, and by this time, other eye had also developed features of pellucid marginal degeneration. So after phacoemulsification, vision improved to 6/9 in both the eyes with correction. So this left eye is also showing this classic crack flow appearance. After 2 months of phacoemulsification, patient complained of redness and diminution of vision in left eye, and similarly inferior temporal corneal perforation was noted in this eye also. And this is the associated picture showing the same. So again here this was managed in the same way with primary sutures and compression sutures. And post-operatively, at the last visit, patient improved in both eyes correction, and patient was 6/9. So coming to the discussion, spontaneous and sequential perforation in PMD is a rare occurrence. So unilateral perforated PMD cases should be watched closely for other eye. And this case is rare as progression in 7th decade is very rare, as non-enzymatic cross-linking occurs in this patient and progression halts in this stage. So there's the similar case report in 56 years old female where the perforation and hydrops happened, and it was managed with tectonic lamellar keratoplasty and subsequent optical penetrating keratoplasty. In this case also, this case was non-surgically managed with bandage contact lens where the perforation was seen. So coming to the conclusion, the intent of this report is to raise the awareness about vision-threatening complications that may happen in PMD, even in the stable eye. Yes, sir. Thank you, sir.
Hi, Komal. It is a rare case, yes, of course. But why was the left eye compression sutures was performed? Did you do it prophylactically? Or,
yes, sir. It was done prophylactically.
Right eye was having perforations, but left eye, did you do?
No, sir. Left eye also came with perforation. That's
both had
why yes, sir. After phacoemulsification, immediately 2 months after phacoemulsification, second eye also perforated, sir.
Okay, so usually in perforations, the first thing is like you start with glue, BCL, and other things. So why was suturing planned? So if there is progression, I think does the literature show says that compression sutures work better than the glue BCL?
No, sir. It's not like that, sir. But as the perforation was, the iris was also come. So it was not possible.
That is what perforation means. Yes, iris will come, but you can manage these cases even with just a glue BCL or any tectonic support. That will work well.
Yes, yes.
So, I mean, what is the indication for compression sutures? Do you want to change the topography or anything? Or
sir, yes, as we can see after first surgery with the compression sutures, the keratometric values change and the post-op BCV has also improved. So we thought for the other. So, but the literature does not say that compression sutures are better than any other modality.
Yes, of course. And the other thing, the pentacam that you showed previously, where left eye was normal, and in the next pentacam, what was the time gap between these two pentacams?
Yes, sir. One was done in 2017, and other was in just prior to cataract surgery, which was in 2021.
Okay, in 4 years. So in between, you didn't keep the patient on follow-up or anything?
Yes, sir. We did topography, but it was done only once, sir. Where there was where the other eye was normal, sir.
They have described even cross-linking in PMD.
Yes, sir. Yes, sir.
So what? Yes, okay, fine. Oh, so you didn't think about cross-linking when it was progressed?
Yes, sir. We thought prior to cataract surgery, cross-linking could have been a better option. But we thought that the patient is of old age, is in 7th decade. Non-enzymatic cross-linking generally happens, and the integrity between the cornea improves. So we thought over a period of time, this must have been stable. But I think we should monitor these patients regularly, sir, and cross-linking could have been a better option, sir, in our case.
How was the
Yes.
IOL power selected in this patient for
Sir,
cathode?
yes, a Barrett to universal toric formula was.
Keratometry, you took the keratometry of topography, Ventacam, or like did you?
Sir, topographic value was taken, sir.
Or topographic value?
Yes, sir. Yes, sir. Yes. Yes.
Thank you, dear judges. We'll move on to the next presentation. Can we have Dr. Anurit Kaur with the case report? Dr. Anurit.
I think we can start with Dr. Niranjana. I think Dr. Anurit is not there. We will.
Dr. Niranjana? Dr. Niranjana Balasubramanian.
Yes, sir. Can you hear me?
Yeah. Could you please start your screen sharing, please?
Yeah.
Could you please go full screen?
Yes. Can you see now?
Yeah. You may start now.
Okay. Very good evening, everyone. This is Dr. Niranjana Balasubramanian. I'll be presenting a peculiar case which we encountered. Pars plana glaucoma drainage tube obstruction by posterior lens capsule in a case of ICE syndrome, and its timely rescue by NDR laser. So, a brief case history: a 44-year-old female with nil systemic illness and no family history of ocular morbidities presented to us with sudden onset blurring of vision and watering in left eye for 20 days. She was hailing from Karnataka and she was already diagnosed to have PACS in right eye and chronic angle closure glaucoma in left eye and had undergone laser iridotomy. And with the past clinical records, we found the baseline IOP to be 12 and 34 and compass ratio of 0.3 and 0.7 in right and left eye respectively. She also had multiple episodes of pain and redness over the past 1 year with no documented evidence of anterior segment inflammation. And the current medications in left eye include topical bimetoprost, fixed combination of brimonidine and temolol, and she was started on systemic acetazolamide a week before, and she was referred to us for further management. At presentation, her best corrected visual acuity was 6.6 in both eyes, and intraocular pressures were 12 and 20 in right and left eye. And the significant findings in right eye include presence of more than 180 degrees of appositional closure and patent iridotomy at 8 and 10 o'clock positions, and otherwise the fundus and visual fields were normal. And in the left eye, there was nearly 360 degree of peripheral anterior synechiae and synechial closure, which was also visualized in gonioscopy, and there was diffuse stromal atrophy and presence of patent iridotomy at 3 sites. The pupillary reactions were sluggish, and she had advanced glaucomatous cupping of 0.85 with concentric thinning of NRR, and she had a ring scotoma and visual fields without involving the fixation. So we arrived at diagnosis of right eye primary angle closure suspect post iridotomy and left eye secondary angle closure glaucoma due to iridocorneal endothelial syndrome with features mimicking essential iris atrophy variant. And as she was referred for further management, our decision was to proceed with pars plana vitrectomy and tube implantation in vitreous cavity. Why was this decision made? Due to the presence of advanced glaucomatous damage and clinical evidence of progression significantly in the past 1 year, and she was already on maximum medical therapy and she was not affording it, and she was also symptomatic. Why was this decision to place a tube in vitreous cavity rather than anterior chamber or the sulcus? Because of presence of critically shallow anterior chambers with extensive synechiae and a clear lens status, we decided to go ahead with implantation in vitreous cavity. And since being a null-valve device, we decided to temporarily occlude the 6-0 vitreal suture. And this is the post-op image showing tube implanted in the vitreous cavity. And the post-operative events at day 2, she had well-formed anterior chambers, and as expected, her pressures were on the higher side due to temporary occlusion of the tubes, and she was asked to continue her dual therapy. And at 7 weeks, a week before her actual review date, she presented to us with mild blurring of vision in her left eye. And on examination, there were shallow chambers with IOP of 2 millimeters of mercury, and the tube is well visualized in the posterior segment. There was mild island folds at the macula and hypotonic macular petit without any choroidal occlusion. As this was expected, the time period was between 5 to 7 weeks, the usual time of absorption of the vitreal ligature. We decided to stop the glaucoma medication and to observe and to do a conservative management. And on subsequent follow-ups, she had well-maintained anterior chambers and her IOP was maintained at early teens without glaucoma medications. She was following up at a local place, and approximately around 1.5 years after her primary surgery, she had underwent uneventful cataract surgery due to progression of cataract and PCIOL implantation. On one fine day, she again presented to us with sudden marked drop in vision in left eye with visual acuity of 1/60 and pressures of 40 millimeters of mercury. She was already started on medical therapy. And on examination, we found diffuse corneal edema, well-formed anterior chambers, and it was quite well-centered IOL in the back, and the posterior segment was normal in the base scan. So what was the reason for this unexplained ocular hypertension? On further examination, we could see that the tip of the RE tube was occluded by the posterior capsule, as we can see in the images. And this was the culprit for the increased intraocular pressure. So what was the management plan? We decided to do focal YAG capsulotomy to relieve the capsular obstruction. And as we can see in this image, the next day of YAG capsulotomy, we could see that the tube obstruction was completely relieved, and we could see the IOP lowered to 10 millimeters of mercury and vision improved to 6/16. So to discuss what are the primary advantages of implanting tube in the vitreous cavity, it is emerging as a primary indication in glaucoma secondary to iridocorneal endothelial system. The risk of worsening corneal endothelial loss in these critically shallow chambers and the chances of tube retraction, occlusion, and migration that would happen with the proliferation of ice membrane all contribute to the reasons of acquisition failure in these cases. And also evidence from literature suggests that the IOP reduction achieved is non-inferior in vitreous cavity implantation compared to anterior chamber implantation. And another point to highlight is tube blockage is the potential cause of increased IOP postoperatively should be promptly identified, and it can be successfully treated with NDI capsulotomy. And the learning points from this is tube obstruction can be successfully managed when promptly identified, and the tubes, when placed in sulcus or vitreous cavity, should be of adequate length to allow visualization and dilated state. And we should not forget the basic that the appropriate distance from the limbus in aphakic and pseudophakic eye should be maintained to avoid close proximity to lens capsule. And in targeted sulcus placement, the tube should be positioned anterior to the IOL, and it should be beyond the rhexis margin so that it avoids blockage by the anterior capsule. And also, the tube position can be done with bevel down or posterior in the vitreous cavity in cases wherein we inadvertently enter close to the lens capsule. As shown in this image, this could help the lens capsule to be at a safer distance from the entry of the tube tip. These are my references, and I thank everyone.
I think it was very well presented. Ashwin, do you have any questions for her? Prasanna, you are on mute.
Ma'am, do you have any questions?
I think she was very comprehensive with her presentation.
Yeah, the discussion and the learning points were very nicely presented.
Yeah, Ashwin, you have any questions?
Yeah, I think we can move to the next presenter.
I think Dr. Anirudh and Dr. Chandra are not presenting. This will be the last talk of this session.
Okay.
Fine. I thank Dr. Nihamida, Dr. Asif, and Dr. Ashwini for coming and presenting, for coming and participating as a judge. Thank you so much, sir and madam.
Thank you.
Thank you, Karthik.
Sir, I
It
think
was nicely organized. Thank you.
Thanks. You need to update the scores in the Excel.
Yeah.
We'll just send that.
Yeah.
Okay. Thank you, sir. Thank you, madam.
Thank you, judges. Thank you.
I'll let Dr. Prasanna take over the next session.
Thank you, Karthik. So do we have the next three judges ready, Karthik?
I think we have Dr. Sujit here and Dr. Deep here. I'll just make a call to Dr. Kunjan if she is available or not.
Yes. Dr. Sujit?
Yeah, Dr. Sujit and Dr. Deep are here.
Yeah, I'm available.
Yes. So we would like to welcome Dr. Sujit to judge the next session, along with Dr. Deep Shekhar Das and Dr. Gunjan. So Dr. Sujit is a consultant at Vision Eye Hospital, Hyderabad, and his areas of interests are oculoplasty and oncology, along with strabismus and neuro-ophthalmology. Deep Shekhar Das, sir, are you there?
Yeah, hello. Am I audible?
Hello. I'm Dr. Prasanna Venkatesh Ramesh.
Hi.
Yes, sir, you're audible, sir. So next, we would like to welcome the next judge, Dr. Deep Shekhar Das, sir, who is an assistant professor of ophthalmology of All India Institute of Medical Science, New Delhi. His areas of interest and specialty are oculo-oncology, oculoplasty, pediatric ophthalmology, and strabismus. I welcome you, sir. So Deep Shekhar Das, sir, and Sujit, sir, you'll be taking care of the next session for judging. And meanwhile, is Dr. Gunjan here?
Yes, I'm here.
Yes. So Dr. Gunjan is also the third judge of the session. So Dr. Gunjan's area of interest is oculo-oncology, oculoplasty, pediatric ophthalmology, and strabismus. So all the three judges, have you got the forms sent to you by Dr. Karthik?
Yes, we have got.
It's a live scoring sheet.
Yeah, all three of you have got it?
Yeah, we all have.
Yes. So without much delay, we'll move to the session, the next one, which is focusing more on the orbit and oculoplasty. And we have three allied panel and judges to discuss the case. I once again request the participants to stick to the time because we do have negative marking. Judges, do please make a note of that. And Karthik, do we have the first speaker ready?
Yeah, Dr. Sindhuja.
Yes,
Okay,
I'm here.
Yeah, Dr. Sindhuja, over to you for your first case presentation. The stage is all yours. Dr. Sindhuja, you can share your screen.
Yeah, 1 second. Can you see my presentation?
Yes, doctor.
Okay. Hi, everyone. I'm Dr. Sindhuja. So there is a saying which goes, find a mask and wear it well. So your true identity, no one can tell. So I'm going to show you how we found out the true culprit and decided to banish it. So a 57-year-old female came to us with recurrent complaints of right eye pain, redness, and photophobia for the past 2 years, which was aggravated for 4 months. So elsewhere, she was diagnosed as chronic blepharokeratoconjunctivitis and treated on and off with intense topical medication. So there was no other significant systemic history or any other ocular history. Her general examination was normal. She had no regional lymphadenopathy or any other mass elsewhere in the body. So coming to the ocular examination, her right eye best corrected visual acuity was 636, left eye was 66. Her IOP, extraocular movements, duct syringing was all normal. Now coming to the right eye ocular examination, as you can see, she had severe reflex blepharospasm in the right eye with loss of flashes in the lower lid, with thickened and inflamed lid margin, and with severe MGD. She also had diffuse conjunctival congestion with severe ocular surface inflammation. And in her cornea, there was 360-degree superficial vascularization with loss of corneal luster, and there was also paracentral thinning also was noted. So how did we proceed with the treatment for this patient? She was provisionally diagnosed as chronic cicatricial conjunctivitis, query ocular cicatricial pemphigoid. So blood investigations was done to rule out any immunological cause. MAN2 and chest X-ray was also normal to rule out the possibility of tuberculosis. So in view of no improvement of symptoms, conjunctival map biopsy was done. So it was taken from 9 sites. And surprisingly, in all the 9 sites, her HPE came out as poorly differentiated meibomian gland carcinoma, which is suggestive of the pegytoid spread. So that is how we found out the culprit behind the mask. So imaging was done to rule out orbital extension, and even there was no evidence of any metastasis. So how did we proceed with this? Is we did a lid sparing exentration, as it was very aggressive tumor involving all the 9 sites, and following which she underwent an external beam radiation for 10 cycles. So currently she's doing fine now. She completed her radiation 1 month back, and she's awaiting for custom fit prosthesis. So this is her post-op picture. As you can see, her socket is healthy. There is only minimal scarring in view of because of the radiation. So why this case is because meibomian gland carcinoma can present in a very non-specific clinical presentation. It can have even like a nodular mass, or it can present as a pegytoid spread, which will mimic a benign inflammatory condition, especially a blepharoconjunctivitis. So it's very difficult to diagnose. The average intervening time between the presentation and diagnosis is usually 1 to 2 years. So the delayed diagnosis results in significant morbidity and even mortality. So poor prognosis is usually seen in bilateral involvement, pegytoid spread if the tumor diameter is more than 10 millimeters, and delayed diagnosis longer than 6 months. So mainly this case I wanted to present is to highlight the importance of lid malignancy masquerading as inflammatory lesion. Any suspicious case which doesn't resolve with treatment, biopsy should be performed, and prompt diagnosis could have reduced the morbidity. Like in this patient, maybe if it was diagnosed earlier, we could have prevented the patient from going in for exenteration. So thank you.
That was well on time, judges. Over to you for discussion. Dr. Sujit,
Dr. Sindhija, did you consult any oncologist? Like,
yeah, we got an oncologist
think of a chemotherapy
as well
option before going for exenteration?
Yeah, we consulted an oncologist as well. So before doing an exenteration, the oncologist only suggested to rule out any orbital extension, do an MRI of the orbit, and even for the metastasis. So then only we proceeded with the
There was no
exenteration.
metastasis.
There was no metastasis. Her
Only
CT test.
purely lid was involved.
Yeah, only lid was involved, but it was involving all the 9 sites of the biopsy which we have taken. So that's
did
why.
you try any topical chemotherapy like mitomycin C?
No, we didn't do anything. We didn't try because I mean literature says that doesn't work because local recurrence is very, very high. Usually even with a local radiation and even chemotherapy also doesn't have much of an effect in a very aggressive kind of meibomian gland carcinoma.
I mean, what was the histopathology report? Can you tell it again? I don't remember.
Histopathology, sorry, I don't have the HP picture, but it came out as a poorly differentiated meibomian gland carcinoma.
Okay. Okay.
So from all the 9 sites which we did the map biopsy, in all the 9 sites.
All the sites were involved.
Involved, yeah.
Okay. 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 It's an excellently managed case.
Thank you.
Thank you.
This is Dr. Deep Shekhar this side.
Yes,
I would just like to know if like how have you done the 9 the biopsies from the 9 sites? Because
we have,
looking at the picture that you have provided initially, it was very unlikely that it doesn't look like a typical. I understand it's a masquerade syndrome which you are trying to show to us, but that's definitely not the typical picture of the way it usually appears. And it's kind of unusual that you never thought of, and like Dr. Sujit was talking about, any form of topical medication. What about the TNM staging about this kind of scenario? How was it done?
Because she didn't have any lymph node involvement. There was no lymphadenopathy as well. So it was only in the orbit. That's why we did even imaging to rule out other metastases also. So CT chest and her USG abdomen was normal. So before going ahead with map biopsy, we did rule out other causes. Like we were first suspecting whether it's an immunological cause. So that's why we did all the blood investigation for that. Then we thought maybe it could be tuberculosis. So we did the biopsy we did a biopsy actually in mind keeping as tuberculosis, but it came out as a meibomian gland carcinoma.
Okay.
So first we actually thought more in favor of TB.
Okay. Was there any eyelid nodule or anything?
No, actually that's the surprising thing. Nothing was there in the lid, except it was inflamed, loss of lashes was there, and severe meibomian gland dysfunction was there.
Okay. I like Dr. Sujit said, I also was like, I am quite interested about looking at the histopath report because it's kind of very unusual. Okay, very nicely presented.
That's why I wanted to share this case, because
But then I would not have gone for an exenteration for this scenario, because except for the positivity of the histopath, the rest of things appear quite normal. And even the MRI
we
is
even
normal,
got a second opinion from the another pathologist as well with the slide block. So we did get opinion before proceeding with an exenteration from at least 2 to 3 people. Then only we went ahead.
Okay.
Thank you, judges, and thank you, Dr. Sindhuja. We'll move to, judges, can we move to the next presentation?
Yes, you can. Yes, you can.
Yeah.
You can move.
Next, we have Dr. Shruti M. Nair to present on oxyplatin-induced unilateral ptosis. Dr. Shruti, please do share your screen. Yeah, and your time starts. Yeah, time starts now.
Good evening, everyone. I'm Dr. Shruti Nair, second year resident. I'm presenting a case of oxaliplatin-induced unilateral ptosis. So history-wise, the patient presented to us a 56-year-old female hailing from Tamil Nadu, housewife by profession, with sudden onset drooping of the left upper lid since 1 week. On further inquiry, there was no significant positive history. Everything was negative. So our negative history included, there was no history of trauma. It was not associated with pain. There was no history of diminution of vision. There was no history of diplopia, suggesting no extraocular involvement. No history of headache, seizures, or vomiting. There was no history of fever or recent vaccination. There was no episode of similar complaints in the past, and not a known, she didn't have any comorbidities or vasculopathies like diabetes, hypertension, and there was no history of past ocular surgeries. The only significant history that we elicited was that she was a known case of adenocarcinoma stomach, and she was on neoadjuvant chemotherapy on the capox regimen at 75% dose, which was a combination of capecitabine and oxaliplatin. So on examination, she was a middle-aged female, well-oriented to time, place, and person, moderately built and poorly nourished. Her vitals were within the normal range. On examination, she had mild pallor, and there was no other significant finding. For systemic examination, including per abdomen and neurological examination, was within normal limits. There was no evidence of any other nervous involvement. On ocular examination, head posture was erect. Hirschberg's test was orthotropic following elevation of the ptotic lid. Extraocular muscle movement was full and free in both eyes. Uncorrected visual acuity was 6/9 and 6/9 parts. The right eye examination was within normal limits, except for a grade 1 nasal pterygium. In the left eye, she had severe ptosis. Conjunctiva also had grade 1 nasal pterygium, and cornea was clear with ulcus, and corneal sensations were intact. Pupils were brisk, and rest anterior segment and fundus was within normal limits. This was a clinical picture of the patient that she presented with on primary gaze. So we can see that right eye was normal with left eye complete severe ptosis, for which ptosis measurement was done. This was the extraocular muscle movement in all gazes. It was seen that there was no restriction on any side. Ptosis measurement showed normal values in the right eye, and the left eye had severe ptosis with only 2 mm of palpable fissure visible. Margin reflex distance was -1 was -5 mm. MRD3 was also -5, and LPS function was fair. Following ISPAC test, no improvement in the ptosis was noted. So our differentials when she presented to us was due to lack of any other significant history and on examination. Most commonly on review of literature, it was found that ischemic would be the most common cause, and infarct causing nerve palsy. other life-threatening or important differentials would be an aneurysm of the posterior communicating artery, which could impinge on the oculomotor nerve, but that would show other signs of extraocular muscle involvement.
13 seconds, doctor, to wind up.
Yes. Horner syndrome would show a small pupil. Ocular myasthenia, usually bilateral, not sudden in onset, or bilateral myositis would have pain, and para-infectious, no other history of fever. So by diagnosis of exclusion, we came to drug-induced ptosis. Investigation, routine blood investigations were sent. CT angiograph was done to rule out any aneurysm or infarct. Management, on review of literature, again, it was found that it's mostly neurotoxicity by oxaliplatin is reversible. And so we will only watch. And in case it's chronic and severe, we can always use ptosis drops or crutch spectacles in the meantime. If it's persistent, surgery can be done based on degree of levator function. So oxaliplatin is a platinum-based chemotherapeutic agent commonly used in GI cancers, and neurotoxicity is a dose-limiting side effect, which can be acute or chronic. So mainly important things that we learned from this case was,
Your time's up, 4 minutes up.
Okay.
Can you summarize and finish it off here?
Nothing. So sudden onset ptosis may be an ocular emergency in case of a vasculopathy. However, in this scenario, in cancer patients, we need to be aware of a diagnosis of drug-induced ptosis, as it's very commonly seen now. That's it. And management will be, we refer to oncologists, and dose reduction with maintenance chemo can be done. Thank you.
Stop sharing.
So thank you for the wonderful presentation. I have some questions.
Yes.
First of all, you just ruled out myasthenia by ISPAC test. So was any neurology consultation also obtained?
Neurology, no, actually, because of the sudden onset and the thing.
Yeah, because you need to rule out myasthenia. And you just did ISPAC test. ACHR antibodies or any other test was not done.
Wasn't,
so that's one thing.
It wasn't a typical presentation, ma'am.
No, it is. Actually, old age unilateral ptosis can be present in around 70% of patients. They can just present with ptosis in myasthenia. Okay, that is one thing. I think a neurological consultation should have been obtained. And second thing, what I saw in that picture which you showed us, patient had severe ptosis. How much was her LPS action?
Was 6 mm.
So it was a moderate type of fair LPS action. But the amount of ptosis is not correlating with the amount of LPS action. So why can't it be an aponeurotic ptosis? As I saw in the picture also, the mid crease was a bit higher. Okay.
Ma'am, but there should be a cause for it, like sudden onset or aponeurotic. There was
Old
no trauma and
again, old age can itself is a risk factor for aponeurotic ptosis, because as your age advances, there's an increased risk for LPS dehiscence, and you will find many patients presenting like that. Okay.
Okay.
So these were two queries. And how long has the patient been on your follow-up?
Actually, patient has visited our OPD only once. She was unable to come back to us. We've spoken to her on call. She says she has improved, but she's unable to come back to the hospital for follow-up currently.
Okay. So, like, how long has been?
It's been a month.
A month. Okay. Thank you.
Can we move to the next talk?
I have few queries.
Okay, please.
When was the oxaliplatin and the other chemotherapy drugs given?
It started 1 week after the second. So she was on the second cycle. So after the second cycle, it started 1 week.
Like, what was the gap between the infusion and the ptosis?
1 week.
1 week.
1 week.
Okay, I mean, I had previously seen oxaliplatin induced ptosis, and previously I had studied regarding this, but no patient had presented after 1 week, because most of them present within half an hour, 2 hours, or within 2 days they present, and by 1 week I think they spontaneously resolve. And the second thing is, I think majority of them never had a severe ptosis. I mean, this is the literature review which I had read. So from that, I'm telling them. And the main important thing is, did it resolve after when you call the patient in the last follow-up?
Yes.
It completely resolved.
Actually, so we spoke to the patient since she's not able to come. She said there is like slight improvement, but not completely resolved. This what she said, but we're yet to see.
Okay. Had it been an oxyplatin-induced complication, because majority of the patients had resolved in the literature, whatever they have suggested.
Yes.
And
Yeah,
whatever the side effect they are seeing is within 1 to 2 days, and it is resolving by maximum say 1 week. It had resolved. So I don't think it's an drug-induced thing.
So,
Like
but
Dr.
literature
Guggen,
also says it can be acute or it can be chronic cumulative neuropathy.
yeah. I mean, if you had read an article about this doses, they had said one is this thing neurotoxicity, and it is very unlikely that neurotoxicity is occurring at the peripheral level. If it is occurring at the peripheral level, it is most likely hyperexcitability because of the leakage of the calcium channels. Okay, that might be because the changes might be occurring at the orbicularis oculi level rather than LPS level. Okay.
Okay, sir.
Okay.
I just want to add one thing. You should have gone for a was there any documentation of the visual function tests, for example, color contrast and all? Because what I've read from and even seen in patients of having oxyplatin toxicity, it's more of a neurotoxicity. So retinal problems will be there.
Yes,
so
so
color
fundus,
contrast might be there.
Fundus was seen. Fundus was within normal limits, but
The likelihood of that happening is higher than a person having ptosis. So, anyways, it was a good presentation. Okay, we can move forward with the next presentation. Okay, thank you.
Thank you, judges, for such a wonderful discussion. Now, moving to the next presenter, Dr. Akshaya Balaji, presenting a case of triple intraocular melanoma. Doctor, can you share your screen? Dr. Akshaya, are you there?
Can you unmute yourself, Dr. Akshaya?
Yeah, you're on mute, doctor. You can unmute yourself on your video and share your screen.
Yes, sir.
Yeah, once you start, we'll start the timer.
The share screen option is in the bottom middle.
Yes, sir. Is it visible, sir?
Yeah, visible. Okay, doctor, you can start presenting.
Good evening, sir. I'm here. I'm presenting a case of unusual presentation of conjunctivo-iridociliary melanocytoma under the guidance of Professor Neviti Lomi. The summary of the case is that we had a 22-year-old female patient who presented with gradual painless diminution of vision in the left eye for the past 6 years, associated with a brownish lesion for 6 years, which was gradually increasing in size. There was no history of trauma, prolonged sun exposure, dry eye, anorexia, weight loss, or radiation exposure. No significant past personal or family history. Patient is a non-smoker and non-alcoholic. General physical examination was within normal limit. On ocular examination, the right eye best corrected visual acuity was 6.6. In the left eye, visual acuity was finger counting at half meter, and intraocular pressure was around 17. And the patient was on IOP was 17 on eye drop dorzolamide and timolol brimonidine combination. The clinical picture of the left eye showed a brownish black conjunctival lesion measuring 8.5 cross 7 mm over the bulbar conjunctiva on the supranasal aspect, and a nasal peripheral anterior synecdoche with irregular pupil which was shifted nasally was noted. On further examination, there was supranasal notching of the pupil, nasally stretched zonules, irregular anterior chamber, and there was pigment release in the anterior chamber, and infratemporal subluxated clear lens was noted. On performing ultrasonogram of the left eye, a supranasal ciliary body mass of 4.7 cross 8.5 mm was seen, and mild to moderate amplitude spikes, which was suggestive of vitreous hemorrhage. We performed an ultrasound biomicroscopy of the left eye. It revealed an irregular mass lesion involving the iris, anterior chamber angle, and the ciliary body with infratemporal subluxation of the lens. With this, we came up with a differential diagnosis of primary acquired melanosis, conjunctival melanoma, melanocytoma, adenocarcinoma, and post-traumatic iris cyst. On the MRI MRI was performed. T1 weighted imaging showed a hyper-intense lesion of the left orbit, and T2 showed a hypo-intense lesion. A well-defined lesion of 7.5 cross 8 mm was noted in T1 image, and there was a in T2 it was homogeneously enhancing lesion on post-contrast images. There was no involvement of the optic nerve, no extraocular extension or involvement of the lens. On impression cytology showed normal conjunctival epithelial cells with numerous goblet cells. Fine needle aspiration cytology was performed using 30 gauge needle from the iris iridociliary mass, and which showed dense melanocytic pigments with entrapped degenerated cells. And 18 fluorodeoxyglucose positron emission tomography of the whole body was performed. It showed irregular subcentimetric enhancing nodular lesion in the infromedial aspect of the left orbit as the site of primary pathology. There was no avid lesions, no avid uptake anywhere else seen in the body. So we came up with a provisional diagnosis of conjunctival iridociliary melanoma. The management was IOP was controlled with anti-glaucoma drugs, and we planned on conjunctival mass excision with amniotic membrane grafting and plaque brachytherapy using cobalt in the same sitting. So this picture shows localized conjunctival excision was done. Then an amniotic, the lesion was marked, amniotic membrane was placed, and then a plaque brachytherapy was done. And this plaque brachytherapy was left in situ for 66 hours as calculated. And then,
doctor, 10 more seconds.
The histopathology report of the conjunctival mass, it revealed a highly pigmented tumor with areas of necrosis. There was no ATPR noted. The tumor cells had large nuclear cytoplasmic ratio was increased, and it was suggestive of melanocytoma of the left eye. And on post-op, 3-month post-op, there was reduction as shown in this picture from 4.7 cross 8.5 to 3.2 cross 2 millimeter. So this case was a melanocytoma, which was initially thought to be a melanoma. Clinically, it is very difficult to differentiate between a melanoma and a melanocytoma. But plaque brachytherapy and is a globe salvaging procedure. Sorry.
You'll have to stop, doctor. Your time's up.
Okay,
yeah, you have to stop sharing. Yeah, judges, over to you. Judges?
Nice presentation, Akshaya. I guess you got scared or what, I don't know. In the later part. I just wanted to know, like, what was the procedure done exactly? What I could make out, you listed PAM as the first differential, which actually doesn't come up. None of the PAMs usually have as in a lesion in the iris as well. It's very unlikely to have that. So I would never keep PAM as even in the differentials list. That is one thing. And what was exactly the surgery that was performed?
So it was a.
Can you just repeat the surgical procedure?
Should I present the slide again, sir?
You can bring up the slide, definitely. Can you just tell me about what exactly was done? Because I could see a cryo as well in the photograph.
No, sir. It was a conjunctival mass excision with amniotic membrane grafting, followed by plaque brachytherapy in the same sitting, sir.
Okay.
This is not a cryo, it's a birth section.
Okay.
And this was the dose, and treatment time was 66.7 hours.
Okay. And what's the latest follow-up of this patient?
So 3 months follow-up, the vision was still finger counting close to face, and the reduction in the mass lesion was noted, sir. From 4.5 cross 8.5, it is now 2 cross 3.2.
Okay, nice. Sujit, you want to add something?
No, I don't have any questions.
Okay. Gunjan?
Yes. So judges, can we move to the next presenter?
Yeah,
If
we
there
can
are more questions.
Yeah, sure.
Thank you, judges. So next we have Dr. Vedavali N, who is going to present on unilateral CCF causing bilateral ocular manifestations. Over to you, doctor. Dr. Vedavali, you're not audible. You have to unmute yourself.
Am I audible, sir?
Yeah, now you are audible.
Is my slides visible, sir?
It's visible. You'll have to go to the slideshow mode.
Now, sir?
Not yet.
You shared, sir?
You have shared. It's not in the slide share mode.
Shared in slide share only, sir.
Can you just move your slides? Is it moving for you?
Yes, sir.
Judges, are you able to see the slides moving, or is it only for me?
No,
that
actually,
No, it's not
the
moving.
slideshow has not been started. What I can make out. The slides are visible.
Okay, Dr. Vedavali, from where are you presenting, from laptop or?
It's a laptop only, sir. From laptop.
Laptop. Okay.
Dr. Vedavali, can you go to the minus mark on the right bottom of your screen? The one minus, and can you press the button next to that? 66, the icon near 66%.
Yeah, now it's moving. Now it's moving.
No, but still it's not in the slideshow.
Yeah.
Dr. Vedavali, can you go to the number 66 on the bottom right hand side of your screen?
I think you can just press F5.
Yeah, F5 also, yeah.
If I make
Okay.
Meanwhile, is Dr. Aditya ready? Aditya, are you ready, Aditya?
नहीं वो नहीं डालना
Dr.
नहीं वो सब नहीं डालना है.
Yes, sir, I'm here, sir.
Dr. Aditya, are you ready with your slides?
Yes, sir.
Yeah, we'll just check for a moment whether we are able to play, or else you will be going next. Just be ready.
Sure.
Sir, is it visible, sir?
Yeah, your presentation is visible, but your slideshow has
अभी
not.
पढ़ो कितना दिख रहा है?
And Dr.
पढ़िए.
Dr. Gunjan.
Oh, sorry.
And Dr.
Now, sir.
Vedavali, you just take your mouse pointer to the bottom, right? Have you taken it? Move your mouse pointer to the bottom. I can't see your mouse pointer yet.
Yes, sir.
You can see it some 80% right bottom. Left to that. You have not taken your go left, not right. Left to that, near the minus mark. Just left to it, little more. Not
Yes,
don't click the minus mark. Just go little more left. There's a icon near the 60%, right? You have to press that.
Near now 41. Left to the 41, you can see a small icon. Can you press that? Yeah.
Yeah, that one.
Yeah, same.
No.
Yeah, your mouse pointer has
Visible
gone.
now, sir.
Your mouse pointer has gone somewhere else.
Okay, do one thing, Doctor. Do you have any videos?
Slideshow is seen, sir.
Do you have any videos in your presentation?
Sir, I think I know what's going on. Dr. Vedavali, could you just
Yes, sir.
make sure you're sharing the right screen? Because when you go for PowerPoint, when you start your slideshow, there are two screens which usually appear for you to share. Go to your Zoom with your slideshow on, go back to your Zoom and choose the screen which is bigger. Only then we will be able to see the screen that you want to share, the full screen. Go back to Zoom. This has to be done with your slideshow on. When you're with your slideshow, press the Windows button in your keyboard and go to the Zoom and choose the right screen. Only then we'll be able to see. Is it working?
No, I think we can present it as such.
Yeah, you can just move the slides as such, Doctor.
Yeah.
You can click on slide 1, slide 2, and you can start. Yeah.
Sorry for the inconvenience, sir.
Yeah,
No
problem.
issues. No issues.
No,
It's all
you can
running.
start.
You can start. Yeah.
evening, everyone. I'm here to present a case of unilateral keratoconcaverous fistula causing bilateral ocular manifestations. Coming to case report, a 35-year-old male came to the OPD with the complaints of protrusion of left eye for the past 3 weeks, which is followed by right eye for the past 1 week. And he had history of headache and history of road traffic accident happened 1 month back, and he had no history of systemic illness. Coming to ophthalmic examination, vision in right eye 6/6, extraocular movements, there is complete restriction of all movements present. Orbit, there is axial proptosis, lids, there is partial ptosis and dilated lid vessels seen, and conjunctiva showed chemosis and corkscrewing of vessels and congestion noted. Cornea clear, anterior chamber normal in depth, other details were normal, and intraocular pressure by rebound tonometry is 23 mm of mercury, and left eye vision 624 not improving with the glasses and pinhole. Extraocular movements, there is a complete restriction of all movements, and there is axial proptosis, and lid showed complete ptosis and dilated lid vessels, and conjunctiva showed chemosis and corkscrewing of vessels and congestion seen. Cornea, there is inferior exposure keratopathy present. Anterior chamber normal in depth, iris color pattern normal, and other details were normal. And intraocular pressure by rebound tonometry is 25 mm of mercury. Fundus examination of right eye, media clear, cup disc ratio of 0.4, vessels normal, and macula FR plus. Left eye, media clear, cup disc ratio of 0.3, dilated and tortuous vessels noted, and there is retinal edema and macula FR dull. Color vision both eye normal, and patient was poor cooperative for fields. And this anterior segment photos showing both eye, there is a congestion, chemosis, and corkscrewing of vessels noted. Left eye more than right eye, and there is axial proptosis. Coming to proptosis evaluation, inspection, both eye, there is axial proptosis and lid closure was inadequate. There is a periorbital fullness noted and dilated lid vessels on the lids present. Conjunctiva showed chemosis and corkscrewing of vessels, and there is inferior scleral show present. Coming mm and left eye showed 30 mm, which reveals a difference of more than around 4 mm. Then the patient was advised a non-contrast MRI brain with orbit, which revealed enlargement of extraocular muscles in left eye. And the patient was underwent digital subtraction angiogram, which revealed left eye. There is a direct communication between left cavernous sinus and cavernous portion of internal carotid artery, and also via the intercavernous sinus, the right cavernous sinus also gets. So then we came to a diagnosis of bilateral axial proptosis, left eye more than right, following a post-traumatic left keratoconcaverous fistula. So why am I presenting this case is unilateral keratoconcaverous fistula with ipsilateral symptoms are far more common, whereas unilateral fistulas with bilateral symptoms are rare. And these are the two articles which supports the rarity.
Dr. Medha, you're breaking up multiple times. And something is wrong with your network, I guess. Am I audible?
You're audible, sir. Yeah, same. I'm also facing the same. I think her net's a bit unstable.
She has some internet connectivity issues. Yeah.
Anyway, time's also up. She's there. Dr. Veda is here.
Yeah, she has.
Dr. Veda is there to answer any questions asked by the judges. Yeah. Veda has joined. Dr. Veda, are you here?
Dr. Veda has joined back. Can you answer the queries by the judges? Dr. Veda?
Yes, sir.
Yeah.
Yes, sir.
Dr. Deep, any questions?
Hi, Dr. Veda. It was a nice presentation. Unfortunately, I think something went wrong with your internet connection. That didn't interrupt much though. Can you just tell me, like, how many cases have been like this before presented? What's the literature review says? Bilateral CCF, bilateral presentation with a unilateral CCF. Is it a direct or indirect kind of thing that you're talking about?
This one is a direct type of fistula, sir.
Okay. Just one question. Do you know what is boomerang sign? Okay. One of your judges have described it. Dr. Sujit has described one of the signs which are seen in CCF. Okay. Thank you. It was a nice presentation.
I have one question. You have
Okay, Dr. Sujit has.
You have auscultated in that patient, right? No, you have auscultated. In your findings, you have written you have heard bruit.
Yes, sir. I have auscultated, sir.
And that means you have auscultated, right? So, did you find any additional sign while doing that? Like, I want to frame it in another question. Like, how can you differentiate it as a direct or indirect fistula? I mean, did you feel any? I mean, I wanted to ask, did you feel any pulsations when you pressed on the globe? Were there any transmitted pulsations? In OPD, you can directly diagnose a CCF when a patient presents post-trauma with a acute onset proptosis and chemosis and condition like your case. Just you have to place a finger on, you have to ask the patient to close his eyes and you have to just place your finger on his eyeball. If you feel pulsations, it's a CCF. That's a simple clinical diagnosis you can make without any imaging. I think she is offline.
Yeah, I think.
Okay, you can continue.
Shall we move the next speaker?
Yeah, sure.
Sure.
Next, we have Dr. Aditya, who's going to have a case on bilateral hypopyon uveitis and masquerade syndrome in a case of breast carcinoma. Yes, Dr. Aditya. Can you share your slides?
Yes, sir. Is it visible, sir?
Yeah, it's visible. You can start, Dr. Aditya. Yes.
Good evening, everyone. I thank the organizers for giving me this opportunity. I'm going to be presenting a case report on bilateral hypopyon uveitis and masquerade syndrome in a carcinoma breast patient. A 60-year-old female came with complaints of throbbing and radiating pain in the left eye. She also had redness and blurring of vision in both eyes for 3 days. There were no relieving factors and no history of prior trauma or ocular surgery. A past history, she was a known case of carcinoma breast for which an incision biopsy of the breast mass had showed invasive ductal carcinoma. She had undergone a radical modified mastectomy 2 months ago. She's also an uncontrolled diabetic with a random sugar level of 382. She's also known hypertensive and hypercholesterolemia on treatment. Her personal and family history were not relevant. General examination, vitals, and systemic examinations were within normal limits. Ocular examination. The right eye, best corrected vision was 612, color vision, lids, conjunctiva were normal. However, the anterior chamber was shallow with cells 1+ and flower grade 2 with a 1 mm hypopyon. The rest of the examination was normal. In the left eye, the patient denied perception of light. The lids, there were lid edema and preseptal cellulitis. Conjunctival chemosis was present. The AC was shallow with cells 3+, flower grade 3, a 2 mm hypopyon was present. Patient also had an ectropion uvea with rubeosus iridis and occlusio pupillae. The IOP was also elevated and was around 24 mm Hg. So this was the right and left eye showing bilateral hypopyon uveitis. Gonioscopy showed visualization up to the trabecular meshwork and dim illumination. A fundus examination on slit lamp with a 78 diopter lens. The right eye media was hazy, but the disc, vessels, and macula appeared normal. Left eye, there was no view of the fundus. So a diagnosis of acute anterior uveitis with angle closure suspect was made, and the patient was started on atropine drops once daily, predacetate hourly in both eyes, 0.5% timolol maleate twice daily, and also oral prednisolone and acetazolamide was given. The uveitis and hypopyon started dissolving after 2 days. However, the patient presented back after 2 weeks to the OPD with pain in the left eye, and examination showed a scleral abscess with conjunctival chemosis and preseptal cellulitis and proptosis. The B scan was done, which showed the low to moderate reflective echoes in the vitreous of the left eye, and there was irregular retinochoroidal effusions with multiple lobulations. The peripapillary thickness of choroid was elevated with 1.9 mm, and early T sign was also noted. MRI also was done, which showed an enlarged left globe with discontinuous nasal sclera, and the enlarged optic nerve and periocular soft tissue edema was also noted. This was the B scan showing an early T sign with increased peripapillary choroidal thickening. So, our diagnosis of panophthalmitis with masquerade syndrome was made, and the patient was referred back to oncology for evaluation. She had received 2 cycles of irradiation and improved. Subsequently, she also had a PET scan done, which showed pleural effusion and pulmonary metastasis with involvement of first rib, for which she again underwent chemotherapy with IV medicines like idiomycin and cyclophosphamide. The uveitis and panophthalmitis resolved completely at the end of 3 months, and the vision improved to 6/9 and 6/60 in the right and left eye, respectively. So, when patients present with similar presentations in the extremities of age group, it is important for us to keep in mind the possibility of a masquerade syndrome. Thank you.
That was well on time, judges. Yeah, over to you for this.
Very nice. Yeah, a very nice presentation, and definitely patients can present with masquerade syndrome, and they may have this panophthalmitis like presentation also sometimes. Only thing which I want to ask you is, how much was vision of the patient when he presented to you with conjunctival abscess and other things?
It was PL negative at presentation when she came to us, and after chemotherapy, 6/60 was the final review. Her vision was 6/60.
Okay, because one of your slides, the last line showed that visual acuity improved to 6/9 from 6/60.
That was the no, ma'am. 6/9 in the right eye and 6/60 in left eye. I should have put it more clearly. Yes.
Okay. Thank you.
Thank you.
Do you have any more questions from the judges? To Dr. Aditya, if we don't have, can we move to the next presenter?
Yes, thank you, sir. Thank you.
Thank you, Aditya. It was a wonderful presentation. Dr. Disha Agarwal, can you on your video? Dr. Disha.
Hello, sir. Can you?
Yeah, I can hear you. I can hear you, doctor. Can you on your video and share the screen? Is your internet connectivity fine, doctor?
Yes, sir. Can you hear me, sir? My screen is on.
Your voice is breaking. Is your connectivity okay?
Now?
Share your screen, doctor. Please do share your screen.
I am sharing my screen. Can you see it?
No. Is anybody else able to see the screen? Or is it only for me?
No, we are not able to see the screen. Her internet connectivity is slow. That is the reason for not, I think. Are you connecting to your mobile data or Wi-Fi? Dr. Disha, please. I think we can move to the next presenter in the meanwhile.
Disha, maybe you try connecting with some other connectivity. We'll finish off the next speaker and come back to you. Dr. Kalaimani, yes. Doctor, are you there? Dr. Kalaimani, yes. Are you ready with your presentation? Dr. Kalaimani? Dr. Gajashri, yes.
Sir, I am there.
Yeah,
Shall I
Dr.
share my screen?
Yeah, please, doctor. Dr. Gajashri, yes, please do share your screen. Judges, we are skipping 2 people, Dr. Disha because of connectivity issues and Dr. Kalaimani, who's apparently not here yet. So we are moving to Dr. Gajashri, yes, on periocular swelling with asthma.
Shall I start, sir?
Yeah, please, doctor. Yeah, you can start.
Good evening to one and all present here. I am here to present a case of a periocular swelling with asthma. It's an uncommon entity. 60-year-old male, he presented with bilateral periorbital swelling for 6 years, which is causing cosmetic concern to the patient. He's a known case of bronchial asthma for 8 years and allergic sinusitis for 5 years. His best corrected visual acuity in the both eyes is 6, color vision contrast with a normal limit. Extraocular movements are minimally limited, -1 in the right eye, and it's full and free in the left eye. Local examination showed superior in the superior aspect, it was a firm, yellowish, non-tender periocular swelling, and fullness is noted in the inferior aspect of the both eye. Pupillary reaction were normal, fundus were within normal limit, rest anterior segment and posterior segment, everything were within normal limit. We have analyzed the patient for any organomegaly or lymphadenopathy, and there is no organomegaly. With this, keeping this in mind, we have a differential diagnosis of Graves' ophthalmopathy, adult onset xanthogranuloma, non-specific orbital inflammatory disease, Langerhans histiocytosis, and lymphoma. So we ruled out Graves' ophthalmopathy by doing a thyroid profile and anti-TPO thyroglobulin antibody. Everything went with a normal limit. In adult onset xanthogranuloma, will confirm it only with the biopsy. Then third one is non-specific orbital inflammatory disease. In this, the patient will be having congestion, and this is a diagnosis of exclusion. And Langerhans histiocytosis is a multi-system disease, which is absent in this case. Lymphoma, again, there is no lymphadenopathy. We went on with the routine investigation. Bone scan was done, serum protein electrolysis, and all connective tissue disorders were ruled out. After that, we did an CT scan, which revealed a bilateral preseptal soft tissue thickening, which is more on the right, with a thickened extraocular muscle. And in the MRI T2 weighted image, again showed a soft tissue thickening, which is seen anterior to the orbital septum, and heterogeneous hyperintensity of the extraocular muscle of the right eye. After that, we have gone with the incisional biopsy, which is taken from right eye upper lid, swelling over the right upper lid. That showed a characteristic Tauton Jane cell along with the lymphocytic infiltration. Hence, we come with the conclusion of it is a case of adult onset xanthogranuloma disease. Since there is no standard protocol for the treatment management, we started the patient with oral steroid, prednisolone 1 mg per kilogram body weight. The swelling started reduced after the 3 months of treatment with a slow tapering. The recurrence happened within 2 weeks of stopping of the steroids. Again, tablet methotrexate 10 mg along with the low dose prednisolone was started, and it is continued for 2 months. The swelling has been reduced, and the patient is under regular follow-up for past 6 months, and there is no recurrent swelling were noted till now. So why this case? Because adult onset xanthogranuloma is an idiopathic inflammatory disease characterized by localized or a systemic proliferation of non-Langerhans Jane cells. There are the 4 clinical types, each has its own classical findings. Adult onset xanthogranuloma is isolated to the anterior orbit, and in the second case, which is our case, adult onset asthma with periocular xanthogranuloma, it is associated with IG proliferative and IgG related diseases. Necrobio xanthogranuloma, it is associated with subcutaneous nodules which ulcerate and fibrosis. Adam-Chester's disease, which is characterized by it is a very it has a very worst prognosis. Retroperitoneal fibrosis and posterior segment infiltration can happen in this. The term AAPOS was described by Jagopi, and it's an uncommon entity because till now less than 50 cases has been reported in the English literature, and there is no standard protocol for this. Asthma tend to appear approximately at the same time when the ocular manifestation starts. Lymphoproliferative disease and IgG related diseases are associated with it. We have ruled out that in this case. Coming to the conclusion, since it is a heterogeneous entity, the thing which the ophthalmologist should rule out is the patient should be appropriately evaluated for the systemic association associated with it and referred to the concerned person. That will reduce the patient getting a life-threatening complication. Clinico-pathological correlation is important for the diagnosis and subclassification of this rare condition. And again, the ophthalmologist are the first patient whom the patient comes with periocular swelling. The timely investigation and referring them to the concerned specialty is advised. Thank you. Thank you, sir.
Judges, over to you for questions.
Hi, Dr. Gajashree. It was a nice presentation. When was the what was the age of the patient? Can you just
60 years old.
60 years. Okay. And you made a diagnosis of xanthogranuloma, right?
Yes, sir.
Okay. You have only tried steroids, IV steroids.
Sir, there is a multimodality treatment has been discussed in the literature. We started with oral steroids since there is a convenience and low cost and patient is very poor. It suggested in the literature are periocular steroids, oral steroid, intralesional steroids, peribulbar steroids also.
Anything other than steroids have been tried or for this
Sir,
patient?
methotrexate has been tried in one of the study. They have given that for 3 to 4 months. But in our case, we gave for 2 months, it started reducing it.
Was there any other systemic like skin lesions as well in this patient, or is it just
Sir,
limited to the periorbita?
Systemically, there was no systemic associated with
Was
this.
there any lesions, xanthomatous lesions anywhere else in the body, or it was just limited to the periorbita?
No, sir. Periorbital only.
Please, there is also a thing like which I think Dr. Sujit and me, we have also contributed to the literature. There's a thing we have initiated to give a trial of cladribine in such cases. Cladribine. Okay, you can just look it up. It might be suitable for this case. Otherwise, it's a very nice presentation. Okay. Over to Dr. Sujit and Dr. Gunjan.
Very well presented, doctor. I mean, have you seen in the literature any role of any sclerosins?
Sir, according to my knowledge, I couldn't find anything.
I mean, for localized small xanthelasma, bleomycin and pingyamycin has been tried. Even I have tried in few patients with considerable good response. But since it's a big lesion, I don't think it will be useful in your case. But for smaller lesions, you can try.
Okay, sir.
Otherwise, I have presented it well.
Thank you, sir.
Thank you, judges. Next, do we have Dr. Disha? Disha, have you joined from a better network?
Yes, sir. Now am I audible?
Yeah, you are very much audible. Yeah.
My screen, can you see, sir?
Yes, yes. Now the connectivity is much better. Yeah, you can proceed, Dr. Disha.
Yeah. Good evening, one and all. I am presenting a case of giant cell reparative granuloma, a rare case scenario mimicking rhabdomyosarcoma. Once again, a masquerade syndrome. It's not moving. Is my screen moving for you, sir?
Oh, no, your screen is not moving. Or can you not slide share and keep the slides and maybe present?
Yeah, okay, sir. Sorry for the disturbance, really. Okay. Can I start once again? Sorry, sir.
Yeah, no issues. Please proceed.
Good evening, one and all. I'm presenting a case of giant cell reparative granuloma, a rare case scenario mimicking rhabdomyosarcoma, once again, masquerade syndrome. I'm presenting a case of a 3-year-old male child with complaints of gradual onset painless progressive swelling over the left eye for last 3 weeks, which was associated with drooping of the eyelid. There was no other positive history like recent trauma, protrusion of eyeball, anything. Antenatal birth and postnatal history were within normal limits. No history of teratogenic drug or radiation exposure. No family history significant. Treatment-wise, the patient was treated outside as a case of preseptal cellulitis without any improvement. CT scan was done, which was suggestive of rhabdomyosarcoma, as we can see, an ill-defined isodense lesion in the extracorneal aspect. And incision biopsy done elsewhere was reported as inconclusive. So when the patient presented to us, we did a systemic examination, which was negative for any other significant swellings in the body. Local examination, he had a 8x5 non-tender firm swelling, which was mobile, not adherent to the underlying structures or the skin, extending superotemporally over the orbit. The incision biopsy that was done outside, there was a sutured incision with healing with primary intention. The anterior segment fundus examination was normal in both the eyes. Management-wise, since the outside biopsy reports were inconclusive, we collaborated with the radiology and pathology department and did an FNAC and MRI, both of which were suggestive of orbital GCRG. As we can see in this pathology histopath smear, the aspirate shows multinucleate giant cells which are osteoclastic in origin and showing associated with lymphocytic and neutrophilic infiltration. So initially, and MRI also shows T2 hyperintense and hypointense lesions. Initially planned for a excision along with pediatric surgery, but post FNAC, the lesion regressed on its own over a week, as we can see in this picture. The child is currently on follow-up with us every 6 monthly, and there has not been any evidence of recurrence. So coming to a discussion, orbital GCRG is a benign fibrous lesion that may be locally destructive, and since it is rare in orbital area, it creates a confusion with rhabdomyosarcoma. It is osteolytic in nature and mostly benign, being more common in females than males. Most commonly in orbit, when it presents, it is there in the roof or in the lateral wall, as in our case. The most common presentations will be proptosis, displacement of the globe, impaired EOM, upper eyelid fullness, and periorbital inflammation. Histology will help in diagnosing, which will have presence of multinucleated giant cells, as we could see in the HPE slide. Surgical excision is the choice of treatment in most cases. However, spontaneous resolution has been reported in many cases according to literature review, and that is what we saw in our case also. So the take-home message is that orbital GCRG should be kept as a rare DD in all cases of orbital masses and fibroosseous lesions. Surgical resection is mostly curative, and however, spontaneous resolution has also been noted and can be watched for initially. Thank you.
Judges, over to you for the discussion.
Nice presentation, Dr. Disha. Can you just tell me
you,
how long did you follow up the patient?
Sir, this is a case that presented to us in March 2022. Till date, the child is on follow-up with us. There has been no evidence of recurrence till date.
Okay. Was there any other lesions anywhere else in the body, or was just
no, sir? As I mentioned in the examination, there was no other swelling, no lymphadenopathy, no other mass lesions in the body, or no other features in the parents as well.
Quite interesting. Okay. Over to Dr. Sujit.
What was the timeline of presentation of swelling and progression like?
Sir, over the 3 weeks it progressed. So over the first week they had presented outside, got treated as preseptal cellulitis, there was no improvement after that. They got a CT done outside, which showed rhabdomyosarcoma, and that's why they underwent incisional biopsy also, but the report was inconclusive. So when the child presented to us, we got the outside biopsy slides reviewed with our pathologist, and deciding with him, we did a FNAC and MRI.
Okay.
Yes, sir.
Okay. So in literature, how many cases has been reported in the orbital area?
Sir, I could find only 4 to 5 cases, and whatever cases I found mostly were in the adult age group. So this being this being in the pediatric age group was a rare case.
What was the mode of management for them?
So like I mentioned, since after the FNAC, the lesion regressed on its own. Initially the plan was surgical excision only, but since
I'm not asking in your case. I'm asking in those 4 cases.
They were excision only, sir.
Excision.
One case has been reported with spontaneous resolution. Other than that, were excision.
Okay, this is a benign condition only, right?
Yes, sir. Mostly benign. It can be locally destructive, but benign mostly. Yes, sir.
Okay. And spontaneous resolution has been, overall in the face, spontaneous resolution has been seen in how much percentage of cases? Because every malignancy can undergo spontaneous resolution. Even RB has been known to undergo spontaneous resolution. So it doesn't mean we have to wait that RB will resolve. So in this giant cell reparative ganglioma, what is the percentage of cases? According to literature which you have gone through, what is the percentage of cases which will undergo spontaneous resolution?
It is rare only, like 1 to 5%. That is why I mentioned that only initially we have to watch for for the first 1 to 2 weeks we can watch, but otherwise we should go ahead with surgical excision.
But most of them present by that time period only. By the time they present, it will be nearly 3 weeks, 4 weeks. Even RMS, rhabdomyosarcoma, they present by that time. By the time they reach the tertiary center where multi-specialty management can be done, it will be the time. So I don't think we should wait for spontaneous resolution. That's what I wanted to tell. it will be detrimental because in orbital cases, the structure is adjacent to CNS. So there is risk of incomplete removal, which again, in this case, like it can undergo malignant transformation.
Yes,
I mean, there is a likely possibility. Okay, very well presented.
So a very well documented and presented case, Dr. Disha. I think you should keep the patient in a very strict follow-up because though
yes,
it has
yes,
resolved now, it can, any day it can come with a very aggressive course. So that
yes,
is
ma'am.
what
The parents
just
are
want to
also
add
very
that.
careful since it's a young child, so they are on a regular follow-up with us.
Okay, thank you.
Thank you.
Judges, we'll move to the last speaker of this session. It's Dr. Sindhuja once again. She has a case on subperiosteal hematoma, the importance in diagnosis and treatment. Dr. Sindhuja, can you on your video and share your screen?
My screen is visible.
Yeah. Hi,
So
louder.
I'll be talking about the importance in diagnosis and management in a case of subperiosteal hematoma. So we had a 12-year-old boy who came with a history of blunt trauma to his left eye while playing 2 weeks ago. So he came with left eye swelling and diplopia. So he was treated elsewhere with oral steroids and antibiotics for around 10 days. So he came to us with no resolution in his symptoms. So there was no other history of defective vision, no head trauma, and no any significant bleeding disorder was there in the patient. So coming to the ocular examination, his right eye was normal and left eye best corrected visual acuity was 6/9 and extraocular movement elevation restriction was noted. So as you can see in the left eye, there is about 3 millimeter inferior dystropia is there with superior fullness. There is mild proptosis and superiorly finger insinuation was not possible. So elevation was also restricted and no RAPD was there, but pupil was sluggishly reacting. Fundus disc and macula was normal. So MRI, we did an MRI orbit. So it was suggestive of a large superior subperiosteal hematoma, as you can see in this picture. So it's a well-defined hyperintense lesion. So he underwent immediate left eye orbital incision and drainage of the hematoma was done. Around 6 ml of blood was drained out and a drain was placed, which was removed after 5 days. So this is the post-op picture of the patient. As you can see, the dystropia is corrected. There is no proptosis and elevation was full. All the movements were full and vision was 6/6. So why did I want to present this case is because it is a rare entity. It constitutes about less than 1% of the orbital space occupying lesions in children. So traumatic subperiosteal hematoma is mostly caused by direct fracture of the orbital bone or by shearing forces. So in this, the fragile emissary vein, which passes through these bones, can easily bleed into this space. So why it is commonly seen in young children is because the periosteum is very loosely attached. And this subperiosteal hematoma, it can enlarge and cause compressive effects, or it can even spontaneously resolve. So in our patients, even after 2 weeks with conservative management, no resolution was noted. So that's why we took the patient for surgery. And this case is to just highlight the importance of imaging in case of a trauma, coming to an accurate diagnosis and timely intervention, mainly to prevent any late sequelae. Thank you.
So it's well on time, judges. Over to you for the discussion, judges.
Nice presentation, Dr. Sindhuja. Am I audible?
Yeah, you're audible.
Yeah. Was any ultrasound done for this patient?
No, it's because since we already did the patient had done an MRI from outside itself and they had come to us. So that's why we didn't do any image B scan for the patient.
Because that's again a non-invasive procedure and doesn't even it's not even that expensive. So you could have just done that. And even people have done ultrasound guided aspiration of the So that is very common that could be done.
Probably since it's 2 weeks duration, the blood would have been little clotted also. So aspiration
unlikely to happen. That is not how it usually happens. So in most cases, if the blood is there, that is an altered blood and it can be even drained out. Okay. Using That is one thing, and you should have looked for like, was there any, what was the fundus picture like? Because I
Fundus
can
was
see there's an
normal.
obvious. It's
Fundus
very
was
unlikely that the fundus will be normal because the globe is already there was obvious dystopia, so there might have been some choroidal folds which I could have like I was expecting might be saying about it. So anyways, otherwise the presentation was very nice and it was expected. I would have waited perhaps for Dr. Gunjan. You can like enlighten me regarding this. Would you have intervened or should you just follow up the patient for a longer duration? What do you feel like?
No. See, I would have waited and I am one of the person who would have waited only because I don't, as the patient is a child, and if there is a resolution on medical management, definitely I would have waited for at least 2 to 3 weeks if the child is not having any visual symptoms. Okay, if there are some visual symptoms like there is distortion of globe or there are some, his vision has reduced or there is RAPD, definitely then early intervention is required. Otherwise, I would have waited for maximum 2 weeks and not beyond that. And one more question, Dr. Sindhuja. There was no fracture in this patient?
No, there was no associated fracture.
Okay. Because one more thing
MRI.
which can be, one more thing which can be there because the child is of growing age.
Yeah.
So sometimes a fracture can present with hematoma in the initial stages, and later, as the bone grows, the bony tables they start shifting away from each other, and there can be a growing orbital roof fracture sort of picture in some patients with herniation of the brain tissue, which can occur through those distorted tables. Okay, so that's why having a follow-up is important again in this patient because a linear fracture can be missed on MRI definitely.
Yeah,
which,
so maybe CT orbit would have been more.
but again, child. So
Ah.
if you look, so radiation exposure is much more in CT. So in a way, it is okay only. But you should follow up this patient, especially in child with a subperiosteal hematoma. They should be followed.
Yeah, there is no need of like emergency. There's no hurry per se, unless there are telltale signs like there's an obvious proptosis causing exposure keratopathy. You cannot do a tarsography, or there are signs that the optic nerve is getting actually compressed or choroidal folds. Like I said, those would have been a definitive indication to proceed with a surgery or any form of intervention. Otherwise, I think the blood will anyways go away.
Conservative.
Yeah, conservative management should have been. Anyways, fine.
Dr. Sindhuja, I'd like to ask one question. So, is there any role of ultrasound? I mean, you have ultrasound, right? So,
Yeah.
Would there have been any role in your case? Since you
Yeah,
said that already CT was done, and I didn't
MRI
think
was
of doing
done.
again. MRI was done. So, would there have been any role of the ocular ultrasound?
Yeah, maybe we could have done an ultrasound also.
In what way?
Pardon?
I mean, it will be helpful in what way?
Maybe if we want to plan like as already sir said, like USG guided aspiration.
No, I mean at the time of presentation, if you had an ultrasound and you were intervening at 2 weeks follow-up, you could have said that by doing ultrasound the size hasn't reduced, so I had intervened. You could have
compare it.
Whatever you had done, you could have judged it by that.
Okay. Actually, the patient came to us after 2 weeks of presentation and treatment. So he was treated elsewhere. So since it was not resolving, then the patient came.
Then according to the parents' history, the size hasn't reduced even 50% also, because hematomas usually resolve at least by 50%.
But they had according to the parents, no, there was no resolution, and they had showed a photo at the initial presentation and when they came to us. So it looked like there was no much resolution of the dystopia or the proptosis.
Okay.
I think we are running out of time.
Yeah.
Okay, nice presentation, Dr. Sindhuja.
Yeah.
Thank you.
Thank you, all the three judges, for an excellent discussion of all the cases. We don't have the next Dr. Kalamani with us. So with that, we'll close the second session. So I would like to thank all the judges, all the presenters, and I'd like to hand over the next session to Dr. Pranesh Ravi. Dr. Pranesh, over to you for the next session.
Thank you, Prasanna. Hi, I'm Dr. Pranesh Ravi. Now we'll be moving towards the next session, session 3, which is on vitreous and retina. The judges for this session are Dr. Obli Ramachandran. Obli sir is an associate consultant from Center for Sight in New Delhi, and his area of interest are diabetic retinopathy. And our next judge is Dr. Nasik Hassan. He is a consultant from Agarwal High Hospital in Tirunelveli. His interests are retina, uvea, and cataract. And then our final judge is Dr. Madana Gopal. So, sir is a consultant from JBI Clinic in Salem, and his area of interest are cataract and scleral fixated diodes. And the first candidate for presentation is Dr. Disha Agarwal, and her title is on fibrinous nodular anti-segment membrane as presentation of chronic post-op end of caused by aspergillus. Over to you, Dr. Disha.
Thank you, sir. Can you?
Yeah, your slide is
see
visible.
my
Yes,
screen?
yes, your slides are visible.
Can I start, sir?
Yes. Judges, can she start? Madan sir, Obli sir,
Yes,
and
yes.
Asik sir.
I'm there.
Yes, I'm here.
Okay. And yes, ma, you can start. Yes, you can start.
Good evening, one and all. I am presenting a case of fibrinous nodular anterior segment membrane as a presentation of chronic postoperative endophthalmitis caused by aspergillus. So I have a case of a 63-year-old female who presented with a history of 2 months diminution of vision, which was gradual in onset, progressive, and associated with pain. The associated history of redness, watering, and intolerance of light was present. There was no other significant ocular history. Patient had undergone uncomplicated cataract surgery 6 months back at a local hospital with good post-op visual recovery. She had history of consultation for these symptoms at a local hospital with no significant improvement, and therefore she was referred to us. On systemic examination, systemic history review, patient was had history of joint pains for which she was taking steroid tablets daily, over-the-counter use. She was not any known case of any diabetes, hypertension, CAD, or immunological disease. General examination was within normal limits. She was obese in build with BMI of 30 kg per meter square. Systemic examination was within normal limits. Coming to ocular examination, in the right eye, she had vision of hand movements with PR accurate. This is the anterior segment photo, which shows thick, irregular, diffuse membranes over the pupil, iris and pupillary plane, which was covering the IOL. Nodular infiltrates are also seen inferiorly and superiorly. There is a fixed less than 1 mm hypopyon. 360-degree circumconic congestion is present. There was no view of the posterior segment, for which we did a B scan. B scan revealed multiple dot-like and membranous echogenicities, which was in the mid-vitreous cavity. There was no evidence of RD, CD, or RCS thickening. Left eye examination was well within normal limits. So we diagnosed the patient as a case of right eye laced postoperative endophthalmitis. Due to the typical presentation of anterior segment membrane, we kept a differential diagnosis of fungal etiology, and we went ahead with anterior segment membrane biopsy and vitreous biopsy for histopath and culture examinations. So the fungal KOH mount showed evidence of septate hyphal growth, and HPE also showed evidence of aspergillus. Hello, is there any problem?
No issues, doctor. You can continue.
Yeah. So we went ahead with and started the patient on topical and systemic amphotericin B. Over the next two days, we didn't notice significant improvement. So we repeated AC wash with core vitrectomy, and patient was started on topical and subconjunctival steroid injection to control the reaction. Post-op 1 month follow-up, patient had a vision of 636 with a clear vitreous cavity, and this was the view of fundus. A brief discussion on the management of fungal endophthalmitis. Vitrectomy is the mainstay of treatment in fungal endophthalmitis, and intravitreal antibiotics and antifungals have been given in the previous first presentations. Other local and systemic risk factors have to be treated. Systemic antibiotics and identification of risk factors is important in the treatment of endogenous cases. The take-home message is fungal etiology is an important DD for chronic postoperative endophthalmitis. Importance of systemic review, like in our case, patient was on chronic steroid use, is important. We tapered the oral steroids after immunologic consultation for our patient. And membranous presentation is more specific towards fungal etiology, mainly aspergillus, and all possible samples have to be collected. Like in our case, we did AC membrane biopsy, which was helpful in diagnosing the aspergillus as the etiology. Thank you.
Well on time, doctor. Very good. Now over to the judges. Madan sir.
Yeah, well presented, doctor. I just got a couple of questions. One, I noticed that no oral antifungals were used. Why is that? And two, why didn't you plan a core vitrectomy at the first sitting itself when you did the membrane wash?
Sir, to answer the first question, the patient was started on systemic amphotericin since we got the first KOH mount as septate hyphal element. So we started on systemic amphotericin B, and when we discharged, we converted it to oral itraconazole after 1 week of systemic amphotericin B. And at the first presentation itself, we didn't go ahead with core vitrectomy since we were not very sure of what we are dealing with. So we thought first we can take a biopsy of the membrane and vitreous, do a gram stain and KOH, and start our treatment plan accordingly.
Thank you. Thank you.
Thank you, sir.
My question is, was oil injected following vitrectomy?
No, sir. Oil was not injected.
Okay. How is the post-op right now? Is he doing fine, or is there any recurrence?
No, sir, there is no recurrence. The patient stopped following up with us after 6 months. So I have the follow-up record still 6 months. Patient was doing very well.
Okay. As far as my experience goes, chronic aspergillosis usually recurs, and it is quite, and that too when it involves the anterior segment also. There is some residual aspergillus somewhere in the ciliary body or somewhere in the bag that it tends to recur, and it tends to recur mostly in the anterior segment. There you can find some fungal balls. But yes, at first presentation, usually your vision is good and then slowly deteriorates. And then after treatment, again, vision becomes good. And then again, it takes time for the aspergillus to grow again. So I would put oil in such cases. I would also add voriconazole in such patients. Voriconazole is studies have shown that voriconazole is better in aspergillosis than
with our for our first as an empirical treatment, we had given intravitreal and intracameral amphotericin, but then since after 48 hours we didn't see any improvement. So along with core vitrectomy, we went ahead with intravitreal voriconazole only, sir.
Okay. Fine. Anyways, presentation was very good. I mean, good documentation and good surgery. Obviously, Dr. Shreyas was my senior, so he is a very good surgeon.
Thank you so much, sir.
Obli, sir?
Nothing. My this thing is same as starting at Nasik. I would have also put an oil, but anyway, good presentation and good documentation.
Thank you.
Yeah. We go ahead to the next presenter, Dr. M.S. Joshmita, her case report on vitreous pearls and veils. Over to you, Joshmita.
Yes, sir.
I think you've clicked on green screen, I presume. So, fine, it's okay. You can start your presentation, Dr. Joshmita.
Okay, sir. Can you see my screen, sir?
Yes, yes. Screen is visible, Doctor.
Good evening, everybody. Today I'm going to talk about vitreous pearls and veils. Coming to the background, neurocysticercosis is a parasitic infection caused by Cysticerca cellulosae, a larval form of T. nasolium. The cyst called the cysticercoid develop in the muscles, eye, brain, spinal cord, and is a common cause of epilepsy. The parasite reaches the posterior segment of the eye via the high flow choroidal circulation through the short ciliary arteries. The predilection to localize at the macula because it's being the thinnest and most vascularized. The larvae enters through the macula and lodges in the subretinal space where it perforates and enters the vitreous cavity. The cysts and scolex have undulating movements. Severe inflammatory response is elicited due to the leakage of the toxins from the micro perforations of the cyst. A clinical presentation, we present a 11-year-old male child who came with complaints of diminution of vision in the right eye, insidious onset and progressive in nature, since 2 weeks, associated with redness and floaters. He came with complaints of parieto-temporal headache since 2 weeks. The vision in the right eye was CF and left eye 6-6 and extraocular movements were full and free. The anterior segment of the right eye showed circumcorneal congestion with anterior chamber cells 2+ and flare. There was no hypopia noted. The posterior segment of the right eye showed multiple large cysts which were translucent with a dense white spot formed by the invaginated scolex, showing typical undulating movements in the vitreous and subretinally. Coming to the laboratory tests, there was leukocytosis with eosinophilia, raised ESR. The ELISA showed IgG antibodies to Tenosium. On A scan, there were high amplitude spikes corresponding to the cyst wall, and the scolex is appreciated. On B scan, we found a well-defined cyst, hyperechoic scolex, suggesting intravitreal cysticercosis, and there was a complete PVD. On MRI, there were a few ring-enhancing lesions in the perilesional edema in the parietal and left medial temporal lobe and the right lobe. And then the child was started on eye drop pomade, prednisolone, tablet prednisolone, albendazole. And then the patient was taken for pars plana vitrectomy of the right eye. The sequel is the ocular cysticercosis was treated and the patient was symptomatically better and the vision improved. However, one of the cysts was buried subretinally as a retinal granuloma. On follow-up, the vision improved to 6-6 in the right eye, and the subretinal granuloma fibrosed, and there was no evidence of active inflammation. Clinical pulse, ocular and orbital cysticercosis has a varied presentations depending upon the site of involvement, number of lesions, and the host immune response. Pars plana vitrectomy is the safest and effective technique to remove the cyst by creating a retinotomy and bringing the cyst into the vitreous cavity. Small subretinal cysticercus can be treated with xenon or argon photocoagulation, transcranially if it is anterior to the equator and transvitreally if posterior to the equator. Thank you, sir.
Well on time, Dr. Joshmita. We'll start with Madan sir, or Nasik sir. Yes, sir.
Yeah, very nice presentation, and it was a classical case of an intravitreal cyst. My one question: how many cysts were there in the eye in that particular patient?
There were 2 cysts, sir.
2 cysts. Okay, and how was it removed? Was it removed en toto, or was it eaten inside the vitreous cavity?
Eaten inside the vitreous cavity, sir.
Yeah. Okay. And where was the granuloma? Was it near in the posterior pole, or was it away from the posterior pole?
It was near the posterior pole only, sir. That's why we could not remove it and we left it there itself.
Okay, okay. But then you must have removed the entire cyst, right? The cyst you must have removed, the cyst, the scolex and everything.
Yes, sir. We had removed one of the cysts fully, sir, but the other one was subretinally inside the retina, so we left that.
Yeah, what was the medical management after that? Was or before that? Was albendazole started before that, or?
Yes, sir. We had started the child on albendazole, sir, 15 mg per kg.
Before the surgery, after the surgery?
Before and after the surgery, sir. We'd given it for 3 weeks.
Ideally, albendazole should be started after the surgery, because if these are live cysts, they tend to, when these cysts die, they secrete these cystic fluids, and that is very harmful for the eye. That will cause increased reactions inside the eye with increased vitritis, and that might even, we might even lose the eye. So obviously, ideally, even when the neurologist sees patients with neocysticercosis, he sends for an ocular examination, rule out ocular cysticercosis, and then starts albendazole. Otherwise, he's just kept on steroids and your anti-epileptics. Yeah, over to Obli sir and others.
Yes.
Obli sir.
Yeah. So I think if it is a live cyst, I would have always taken it in toto, because eating it inside the cavity would always elicit dense anaphylactic reaction. But yeah, subretinally, if something was there, I would have also left it in situ. And neuroimaging, did it show any other cysts inside the brain?
Yes, sir. There were multiple cysts in the parietal region and the temporal.
So was she, she's on a follow-up with any neurosurgeon?
Yes, sir. The child is follow-up with the pediatric neurologist.
Yeah, that is more important, because eye is still fine, because these live cysts can always cause epilepsy and life-threatening other conditions. But yeah, good case, good presentation.
Thank you, sir.
Yeah, well presented. There are a few subretinal cysts that I've removed using a flute needle by just opening up the retina and using a soft needle you can remove, but somehow I got logged out when you were presenting that surgical this thing. So yeah, well presented.
Thank you, sir.
It's not a problem. Yeah.
Thank you, judges. So now moving on to our next presenter, Dr. N. Shastika. She will be presenting a case on lipemia retinalis with a systemic comorbidity. Over to you, Dr. Shastika. You can share your slides, Doctor. The slides are visible, Doctor. You can start your presentation.
Good evening all. This is Shastika, postgraduate from Government Salem Medical College, hereby presenting an interesting case of lipemia retinalis. A 15 years old female child, she was newly diagnosed as diabetes mellitus a week back, and she came to us for diabetic retinopathy screening. She was already on injection insulin and oral hypoglycemic drugs with no other significant family history. Her unaided visual acuity was 6.6 in both the eyes. Her adnexa and eyelids was normal in both the eyes. There was no arcus juvenalis. Her EOM was full, IOP was within normal range, her color vision was normal. This is the anti-segment imaging of the child, which is normal. Moving on to fundus examination, we noticed a white creamy colored appearance of the peripheral retinal vessels, which were extending from the periphery towards the optic disc, involving the posterior pole in both the eyes, which led to the finding of moderate lipemia retinalis of grade 2. In OCT, we could see hyperreflective spots in the inner retinal layers, which is due to the triglyceride and chylomicrons present in the blood vessels. On examination, she was thin-built. There was loss of buccal pad of fat. Acanthosis nigricans was present in the nape of neck. Systemic examination, she had a distended abdomen with shifting fluid dullness. Cardiology, respiratory, and CNS was within normal range. Moving on to investigation, she was started with lipid profile. Her triglycerides were highly elevated of more than 3,500. Her total cholesterol and LDL was elevated. Blood sugars were highly elevated. Her routine RFT and vitals were normal. Her TSHs were elevated. Her ECG echo revealed hypertrophic cardiomyopathy. With all the above investigations, we concluded it as a case of Berardinelli-Seep type 1 syndrome. Out of 5 major criteria, she was having 3 criteria such as congenital lipodystrophy, elevated serum concentration of triglyceride, and insulin resistance. And out of 6 minor criteria, she was having precocious puberty, cardiomyopathy, and intellectual disability. So with satisfying 3 major and 2 minor criteria, her diagnosis was confirmed as Berardinelli-Seep syndrome, and cardiology, endocrinology, and diabetology opinions were obtained. And she was treated with tablet fenofibrate, tablet pioglitazone, and atorvastatin, and dietary control was advised. So lipemia retinalis is a rare manifestation of hypertriglyceridemia. Once the triglyceride levels they return to normal, the ocular findings of lipemia retinalis will fully resolve. The fundus will usually normalize within 4 to 6 weeks. So here I present this case for its rarity and for wide clinical spectrum, and it's always been a diagnostic challenge to recognize the syndrome at the earliest, allowing us to early intervene and for the better prognosis of the child. So mostly lipemia retinalis it will not have any visual impairment, so leading to most probably missing the diagnosis. Even in our case, it was an incidental finding. This case it provides shows the important role of an ophthalmologist in the early diagnosis and the treatment of a life-threatening disease. I hope this rare case presentation from our experience will enlighten all our knowledge. Thank you.
Thank you, Shastika. Nice presentation and nice slides you had. Now over to the judges. Madan sir.
Madan.
Nothing specific to add. Well presented. I mean, did the patient come to you for follow-up or anything? Were you able to follow that patient up? No.
Yes, sir. She's on regular follow-up for every 4 weeks. We have advised her, sir. Routinely, when she comes for diabetology and endocrinology, she used to visit us, sir, for retina examination. We have explained about she's having high risk for vascular occlusion, and we have explained her, sir.
Try to get a fundus picture again.
Yes, sir.
Well done.
Obli, sir.
Lipemic retinalis, I think it disappears as quickly as it comes. And what are the grades of lipemic retinalis? You were telling about moderate lipemic retinalis grade 2. What are the grades, if you can elaborate about that?
So there are 3 grades, sir, like early, moderate, and market, sir. If the triglyceride level is within 2,500 to 3,500, it is early, sir. If it is more than 3,500 to 5,000, it is moderate. If it is more than 500, it is advanced. Whereas in retina, in early, we see only the peripheral vessel involvement. If posterior pole is involved, it is marked. In severe, we can see the salmon appearance of the fundus, sir. It will be salmon colored fundus in severe cases.
Good. Okay, nice presentation.
Dr. Nasik, sir.
Yeah, very nice presentation. This is one case which shows that the eye is the window to the body. So, good that we found this, so that this will obviously save our life. The one thing, and I don't have anything extra to add. It was a nice presentation. Just that we have to keep her on regular follow-up. Explain if a vision is good, right? 6.6 must be 6.6. Yeah, you have to explain her regarding venous occlusions. Otherwise, any other signs, orbital or ocular signs of hyperlipidemia?
No, sir. There was no ocular, arcus analysis.
Or xanthelasma. Okay.
Xanthelasma, skin xanthelasma was not there, sir.
Okay, very good. Thank you.
Now on to our next presenter, Dr. Mrugang Patel. Dr. Mrugang is going to present a case on reactivation of toxoplasmosis in an young adult. Over to you, Dr. Mrugang.
Thank you, sir.
Your slides are visible. Yes.
Good evening, judges. So today I'm going to present a case report of reactivation of ocular toxoplasmosis. So a 29-year-old gentleman presented with the diminution of vision, floaters in left eye since 4 days. He is a known case of diabetes mellitus. He gives history of similar complaints in the past in left eye. On presentation, visual acuity unaided in right eye was 6.6, while in the left eye, visual acuity was 6.24. On ocular examination, right eye anterior segment was within normal limit. IOP by GAT was 18 mmHg, and posterior segment in the right eye was normal. In the left eye anterior segment, there was conjunctival mild congestion. Keratic precipitates were there, and cells 1+ was present. IOP in the left eye by GAT was 26 mmHg. Posterior segment, there were retrolental cells were there. Vitritis of grade 2. Active retinochoroiditis lesion nearer to the chorioretinal scar in the macular region was present. This is a slit lamp examination where you can see there is a keratic precipitates in first 2 images. Here in the third image, you can see there is a presence of retrolental cells in the anterior vitreous. Coming to the fundus examination of the left eye, grayish yellow lesion with irregular margins of approximately 0.5 disc diameter with a satellite lesion. An adjacent hyperpigmented area of 0.5 disc diameter below the fovea was present. An isolated hyperpigmented ill-defined lesion of 0.25 disc diameter inferior to the active lesion was also seen, suggestive of the satellite lesion. And vitreous haze was also present, which was suggestive of vitritis. So a clinical diagnosis of left eye pan-uveitis was made. And this was a straightforward diagnosis of ocular toxoplasmosis because of presence of focal retinitis lesion with overlying vitreous inflammation, classical appearance of headlight in fog. Accompanied adjacent pigmented retinochoroidal scar was also present with presence of keratic precipitates and high intraocular pressure. So investigation for toxoplasmosis gondii was sent, and it came out to be IgG positive. ESR and chest X-ray was normal. HIV 1-2 was negative, and MAN2 test was also negative. So we started the patient on trimethoprim plus sulfamethoxazole, that is code trimoxazole, double strength BD, and it was initiated with the intraventral clindamycin 1.5 mg per 0.1 ml on day 1 and day 3. With oral prednisolone acetate 1 mg per kg was also started after 48 hours of antibiotic initiation in tapering fashion with the topical timolol maleate 0.5%. was also started in left eye to control the high intraocular pressure. So this was the on presentation where here you can see the vitritis with presenting vision of 624. This was the post-op day 1 after the injection, where again the condition, the status was same. Again, a second injection was given on day 2, and day 3 you can see the status is still same, but there is a improvement in the vitreous inflammation. There is a reduction in the vitreous inflammation, and patient was improving gradually on the subsequent follow-ups. So after 4 weeks, this is the on presentation fundus image where you can see there is significant vitritis. And after 4 weeks, you can see there is a remarkable response to the treatment with the lesion also subsiding. Here, the vitreous was clear. So ocular toxoplasmosis is a common cause of infective posterior uveitis in immunocompetent individual. Cat as a definitive host and human as an intermediate host. So my conclusion will be like toxoplasma chorioretinitis does not need to be an immunocompromising state to occur. So it can occur in immunocompetent patient also. Typical chorioretinal lesion along with a positive IgG for toxoplasma allows the diagnosis of ocular toxoplasmosis. Early diagnosis and prompt treatment are crucial for preserving vision and preventing further damages to the eye. And intravitreal antibiotic are recommended if the lesion involves the macula, and addition of oral antibiotics also fastens the recovery. Thank you.
Yeah, well presented, doctor. One question.
Yes,
You
sir.
mentioned injections. Was that systemic injection or intravitreal injection?
Sir, it was intravitreal injection.
I see. Anything specific? Why would you go for an intravitreal injection rather than systemic? Why
Sir,
would you understand my question?
Yes, sir. Yes, sir. Sir, since we wanted to, patient presented to us very in earlier to us. So we wanted the lesion, since the lesion was in macula, and we wanted the patient to improve faster. So we chose to give intravitreal injection along with systemic antibiotics.
Okay.
The classical triple therapy was also initiated on the same day. Patient was counseled, and on the second day, the patient we counseled the patient that we want to give intravitreal injection. Since there is an occurrence of reactivation, he gives similar complaint. He also gives some 12 years back. So we told that we convinced the patient, and patient agreed that okay, you can go ahead with the injection. So with the 2 injection, patient showed drastic improvement, and patient was also happy for that the improvement, and there was also improvement in the vision. So we thought to give a trial of intravitreal clindamycin to this patient, and the results were remarkable.
Good. Thank you.
Yeah. How many injections were given, and what is the gap between those injections?
So total of 2 injections were given. The patient presented on us, and the next day, day 1, the injection was given, and in the gap of 1 day, second injection was given. So total of 2 injections on day 1 and day 2.
Okay, I have not heard about consecutive daily injections, but
no, sir. The injections was not daily. It was given with a gap of 1 day. So on day 1 and day 3, sorry.
Day 1 and day 3.
Yes,
yeah, I mean, I have just given 1 injection. Most of my patients have done well with systemic antibiotics and steroids. I have given 1 dose of clindamycin along, but I also give dexamethasone along with that, a shorter acting steroid. So they have shown good. Otherwise, it's a classical straightforward case. Good case presentation.
Thank you, sir.
Yeah, pretty straightforward and classical presentation, and yeah, intravitreal clindamycin can be given, but yeah, the thing is that you shouldn't be giving it too frequently, because any penetrative thing, acute inflammation can risk the inflammation going out of hand. So anyway, it's a good presentation.
Thank you, sir.
Good presentation, Dr. Mrugant. Our next participant is Dr. Sindhuja. She'll be presenting a case report on the surgical outcome of macular hole in gyrate atrophy and VKH syndrome. Over to you, Dr. Sindhuja.
Am I audible?
Your slides are visible. Yeah, you can start. Yes, doctor, you can start.
Is it audible?
Not audible.
Your voice is not audible.
Dr. Sindhuja, your voice is not audible.
Doctor, you are not audible. Your voice is a bit muffled. You can check your microphone settings.
Dr. Sindhuja, what device are you using for presentation?
Laptop.
I think your laptop mic is the issue. Is this the same device you used for the trial run yesterday?
Yes, sir.
Oh, I think something must be covering your mic. Or in the mic settings, you must have chosen stereo instead of normal, mostly. Do you want some time? Is the next participant ready? Dr. Sivaranjani. Dr. Sivaranjani, are you ready?
I think Dr. Sivaranjani is not in the list, I think. Dr. Sivaranjani?
She's there.
He's not there.
She's not there, no? Okay. Dr. Priyanka? Yeah, Dr. Priyanka, she's there.
Yeah.
She's online. Can you... Hi, Dr. Priyanka. Can you present? Are you ready?
Yes, sir.
Very good. Okay, now over to Dr. Priyanka. Dr. Priyanka will be presenting on double immunosuppression leading to CMV retinitis. Your slides are visible.
Yes, sir. A 37-year-old male who came with complaints of gradual progressive diminution of vision in the right eye for 2 months, and it was also associated with redness and floaters in the right eye for 2 months. There is no significant negative history, like no other complaints in the other eye or in the past. No history of any other ocular procedure or any ocular trauma. He was a known case of diabetes for 2 years, and he's a known case of HIV and on ART for 8 years. He's a known case of non-Hodgkin lymphoma, completed chemotherapy of R-CHOP regimen 4 months back, and now currently on radiotherapy. So systemic examination was within normal limits, well built and nourished. Vitals were stable. There is no skin lesions or no lesions in the oral cavity. The rest of the examination were within normal limits. Coming to ocular examination, is uncorrected visual acuity in the right eye was 6/9, and the left eye was improving to 6/6. And in the right eye, there was a congenital congestion, along with a few pigment and small KPs scattered inferiorly over the cornea, and there was pigments on the anterior lens capsule. And the left eye was within normal limits. In the slit lamp, there was no cells or no retrolental cells. Dilated fundus examination of the right eye, showing grade 1 vitritis, and there was also a large confluent yellowish necrotic area nasal to the disc, along with the granular borders, which is suggestive of active infection. And there was also sclerosed vessel connecting the disc to the lesion. And there was multiple dot blood hemorrhages all over the posterior pole in the both eyes, and there is also microaneurysms in both eyes, suggestive of moderate NPDR. So we came to the clinical diagnosis of right eye active CMV retinitis in the zone 1, along with grade 1 vitritis, with moderate NPDR and with AIDS and non-Hodgkin lymphoma. So we did a complete blood count which showed reduced TLC, which is due to the effect of chemotherapy and radiotherapy, and other basic baseline examination with the normal limits. But his CD4 count was 114, which was more than 50, which is specific for CMV retinitis. And AC-TAP was positive for CMV.
You are in 6-minute congestion. You are on the fastest route. You will arrive at 8:15.
Excuse me, can you hear me?
Yeah. It was just a crosstalk. No issues, doctor. You can continue.
So since it's a zone 1, it is a sight-threatening disease. So we went with the ocular therapy of intravitreal ganciclovir 2 mg per 0.1 ml, given 2 times per week, and also systemic therapy of continuing a heart therapy along with intravenous ganciclovir 5 mg per kg OD for 14 days. So CMV retinitis is the most common opportunity infection in the eye. It is a full thickness retinal infection because of the necrosis, and it also complicates to retinal breaks and retinal detachments. CD4 count will be less than 50 cells per microliter in CMV retinitis. So but the lesion will become active and aggressive on systemic immunosuppression. Like in our case, we gave patient was on chemotherapy and radiotherapy. So key point is that heart therapy actually helps to reduce HIV replication, also elevates the CD4 counts, and it also reduces this mortality and morbidity. Apart from heart therapy, it is also vital to give anti-CMV therapy. So this presentation of this patient is due to the compromised functionality of the immune cell. So that even though the CD4 count was more than 50, but that functionality of that immune cells were compromised because of the chemo and radiotherapy. So when do we stop maintenance therapy for this kind of patient is when the CD4 counts is more than 100 for at least 3 to 6 months and the lesions are inactive. So we have to follow up the patient for every 3 months, even after stopping maintenance therapy. Thank you.
Nice presentation, Doctor. Over to the judges.
I would like to ask one question. Usually CMV retinitis rarely comes with floaters or vitritis. Why do you think your patient had vitritis?
So that is because that the immune system was still active. Patient had completed the chemotherapy 4 months back. So the effect would have been gone by now.
Yeah, exactly. The CD4 count was more than 100 in your patient, and that's why he had some. Usually, you see vitritis in case of CMV retinitis in immunocompetent patients.
Yes, sir. Yes.
Very good. How do you differentiate between an ARN and a CMV retinitis? Do you want to say some points?
ARN, in CMV retinitis, actually it spreads scientifically and it mostly occurs in the posterior periphery. But in ARN, it actually occurs in the immunocompetent individuals, so vitritis will be very much pronounced compared to CMV retinitis.
Yeah, good. Over to Dr. Madan, sir.
Well presented, doctor. Just one question. You'll be following up this patient, and what's on the top of your mind when you follow up? What will you be looking for?
So we will be looking at any active lesion that is coming, like granular border or any leading borders of CMV retinitis will be increasing in size if it's active.
After
that? Like in this case, I will look for the vitritis also. If it recurs, then again vitritis will develop.
After that?
Other eye involvement.
We like to see for breaks.
Yes, sir. Breaks and detachments are common in CMV retinitis.
Okay. Thanks. Well done.
Thank you, sir.
Obli, sir. Your voice is. So your voice is not clear, sir. Your voice is not clear.
Obli, your voice is breaking. Not able to. Obli, sir.
I think Obli, sir, has poor connectivity. It's okay. We can move on to the participant. Dr. Hemant. Hemant will be presenting a case on Turson syndrome. Dr. Hemant, can you share your slide, please?
Yes, sir.
Yes.
Are you able to see my slides,
yes,
sir?
I'm able to see your slides, doctor. You can slideshow. Yes, very much visible, doctor. Yes, you can start presenting.
Good evening, everyone. Today I'll be presenting a case about Turson syndrome. 26-year-old male patient who was working as a mechanic came with a complaints of sudden onset painless diminution of vision in both eyes for the past 2 months, which was following a road traffic accident. And then he also had an episode of loss of consciousness for around 2 hours post-accident. And then it was also associated with the floaters in both eyes since then. And then he is not a known case of any diabetes mellitus or any hypertensive. And then he is also not a known case of any bleeding disorder. Then coming to the examination, general physical examination was within normal limits. And then coming to the ocular examination of the right eye, the vision in the right eye was 1/60 and the PR was accurate. And then the refraction showed a dull glow. And then the pupils were 3 mm. Direct and consensual reflexes were brisk. and then IOP by Goldman's appellation tonometer was within the normal limits. And then coming to the ocular examination of the left eye, the visual acuity was 2/60 and the PR was accurate. And then the refraction showed a dull glow. And then the pupils were 3 mm D and C brisk. There was no evidence of any RAPD. So and the IOP was within normal limits. And then coming to fundus examination, both eye media was hazy due to dispersed vitreous hemorrhage. And then the disc was hazily seen. And then the rest details could not be made out. So we had to do a USG B scan. Both eye revealed dot-like echogenicities of mild to moderate intensity, which was present in the mid to posterior vitreous cavity, which was persistent even in the low gain, which was suggestive of a probable vitreous hemorrhage. There was no evidence of any retinal detachment. When we did the NCCT brain, we could make out left frontal subarachnoid hemorrhage and also left parietal subdural hemorrhage. The management plan was the patient underwent sequential pars plana vitrectomy with internal limiting membrane peeling for both eyes. And then this is a surgical video of the same patient. You can see the ILM peeling. Then there you can see the sub-ILM bleed, which was noted after doing core vitrectomy. And then following with the blood was dispersed with a vitreous cutter and then it was aspirated. The post-op status of the patient was at around 1 month post-op. The patient's visual acuity in both the eyes was 6/6. And then the fundus was within normal limits. These are the fundus picture at the end of 1 month. And then coming to the discussion, Terson syndrome is associated with intraocular hemorrhage, which is also associated with intracranial hemorrhage. So actually the exact pathophysiology is not known. So like any case of intraocular hemorrhage frequently will resolve spontaneously if it's a Terson syndrome. And then even the visual loss is usually reversible, if treated timely. So actually considering the young age of our patient with persistent bilateral macula involving vitreous hemorrhage, we had to go ahead with vitrectomy. That resulted in good visual outcome. The conclusion of my case was that Terson syndrome is rare, but it is often undiagnosed. Therefore, any case of a multi-layered intraocular hemorrhage with intracranial hemorrhage should always consider for the Terson syndrome. So, and then any case of a bilateral macula involving vitreous hemorrhage should always consider for early vitrectomy. Thank you.
Well documented and well presented, Dr. Hemant. Just one question. You spoke about multi-layered hemorrhage. Where else can you expect a multi-layered hemorrhage? I mean, forget the intracranial hemorrhage.
Yes, sir.
Which other retinal condition would you be having multi-layered hemorrhage? Any idea?
Actually in RAM we can see multi-layered hemorrhages, and then also we can see with retinopathy associated with any blood dyscrasias in any leukemic patients, we can see multi-layered retinal hemorrhages, and then battered baby syndrome.
Yes.
Also we can see multi-layered hemorrhages.
Good.
Thank you, sir.
Good presentation. I mean, good videos also. Ideally, Terson syndrome, most of the bleed is over the retina, so they usually end up with very good prognosis. Do you know any relationship between your the outcomes, neurological outcomes, or the mortality outcomes of patients with Terson syndrome and subarachnoid hemorrhage? Any idea on that?
Sir, actually, a few of the literature says neurologically also the patients will improve in a much better way, but it will take a longer duration, compared to the ocular status. This is what I know.
So one thing I remember is patients of subarachnoid hemorrhage with Tersons have a higher mortality rate than without Tersons. That is one thing I remember during my days. But otherwise, yeah, it's a good presentation, and yes, very good outcome also. Thank you.
Thank you, sir.
What is the hypothesis for the bleed to occur sub-ILM? Do you know about that?
Sir, this subdural hemorrhage, it might increase the pressure, intracranial pressure, and then that might cause venous stasis in the retina, and then due to increased intravenous pressure, that might cause rupture of the peripapillary vessels, which will lead to ILM bleed. One thing is
rupture of the peripapillary vessel. Yeah.
Yes, sir.
Yeah. Okay. Okay. Good presentation. Yeah.
Thank you, sir.
Thank you, judges. Now over to the next presenter, Dr. Aishwarya Anandi. She'll be presenting a case of choroidal melanoma. Dr. Hemant, you can stop sharing, Hemant.
Yes.
And Dr. Sindhuja, are you ready? By any chance, is your mic thing sorted out? Dr. Aishwarya, just give me 1 second. Dr.
Yes, sir.
Sindhuja, is your mic thing sorted out? Will you be able to present next?
Yes, sir. Is it audible now?
Yeah, it's audible now. Yes,
Okay.
doctor. Okay, you'll be presenting after Dr. Aishwarya. Okay, Dr. Aishwarya, you can move ahead. Yes, you can present.
Yes, sir. Good evening, everyone. Today, I'll be presenting a case of atypical choroidal melanoma and myself, Dr. Aishwarya Anandi. And 49-year-old male presented with a chief complaint of progressive decrease in vision in the right eye for the past 3 months. He gave a past history of significant weight loss for the past 6 months. And there was no other significant positive history given by the patient, and the general and systemic examination were within normal limits. On examination, his right eye had an best-corrected visual acuity of 6/24 and left eye had 6/12. Anterior segment examination was normal in both the eyes. On fundus examination, right eye showed a grayish mass lesion, the morphology and extent of which could not be made out due to the surrounding subretinal fluid and the associated exudative RD, and the left eye showed a macular scar. This is the fundus image of the patient, and this image shows the grayish mass lesion, the morphology of which could not be made out clearly. This is a multicolor photography of the patient. And B scan was done for this patient, which showed a dome-shaped mass lesion with homogeneous echogenicity, with a line echo of moderate to high reflectivity attached to the disc, which was suggestive of an exudative retinal detachment secondary to an choroidal mass lesion. This is the OCT of the patient showing an choroidal mass elevation with subretinal fluid causing foveal detachment. Fundus autofluorescence showed an hypoautofluorescent lesion in the superotemporal quadrant. Fundus fluorescent angiography showed an hypofluorescent elevated lesion in the superotemporal quadrant with the hyperfluorescence in the borders. And these are the imaging modalities of the left eye, which was suggestive of a macular scar. So why this case? This case gave us a diagnostic dilemma because none of the features were suggestive of a typical choroidal melanoma. D scan did not show an choroidal excavation or acoustic hollowing or a typical cholesterol appearance. Fundus autofluorescence showed an hypoautofluorescent image, and FFA did not show dual circulation. So we went up with the provisional diagnosis of amelanotic choroidal melanoma or an choroidal hemangioma with exudative retinal detachment in the right eye and the macular scar in the left eye. Patient was ordered for further investigations like MRI and PET scan, and systemic evaluation was ordered, and patient was referred to an oncologist to look for any metastatic. MRI showed an T1 hyperintense lesion, which was suggestive of an malignant lesion with no obvious infiltration beyond the sclera, which was consistent with an choroidal melanoma. And PET scan did not show any evidence of metabolic activity elsewhere in the body. Hence, and final diagnosis of a large-sized choroidal melanoma with exudative retinal detachment with no nodes involvement and no systemic metastasis was made. And the left eye showed a macular scar. And the next challenge we faced with this case is being the seeing eye with good vision and considering the macular scar status of the other eye, the following treatment options were considered for this patient: plaque brachytherapy or an enucleation. But based on the opinion of our ocular oncologist and based on the COMS study and considering the size of the tumor, enucleation and histopathological analysis was the best and only option for this patient, which was available. Hence, we went ahead with the enucleation, and HPA turned out to show an high nuclear grade choroidal melanoma. And to our surprise, HPA showed a transscleral breach, which was not picked up on the MRI, and it showed predominant type B cells. So the systemic treatment plan, which was planned for this patient, was external beam radiotherapy to the bed, and it has been completed. And after the external beam radiotherapy has been completed for this patient, prosthesis has been provided for cosmetic purpose. So what next for this patient? Tight surveillance in the form of annual follow-up and systemic evaluation has to be done because 5-year relative survival rate for large choroidal melanomas is only 47%. So take-home message from this is high clinical suspicion is required. Clinically, we have to differentiate between an AV and a melanoma. Uveal melanomas can have a typical and atypical feature. Multidisciplinary approach is required for all these kind of cases, and long-term follow-up and strict surveillance post-primary treatment is necessary in these cases. Thank you.
Thanks, doctor. Well presented with good images and follow-up. If you're following up this patient for, let's say, a certain period of time, where would you expect a secondary to be seen if at all he has to develop a secondary?
Secondary is most common in liver, sir. Any choroidal and uveal melanomas, the first site commonly noted is liver, second is lungs, sir.
On the contrary, if a patient were to have a secondary metastasis in the eye, which would be the primary site? Where would you be looking for a tumor in the body?
In this case, there had been an enucleation. Probably in ciliary body or in iris.
No, my question is, if you suppose you're dealing with a secondary in the eye,
okay, sir.
Which is the most common site for the primary lesion? Not in your case. This is a choroidal melanoma. Suppose you were dealing with a secondary.
Can be skin melanoma, which has secondaries in the eye, sir.
Okay, you're talking about melanomas. I'm talking about secondaries in general.
Okay, sir.
If it's a woman, it's breast carcinoma.
Breast carcinoma.
And it's lung.
Okay, sir.
They're commonly present as secondaries, and that should be something high in your mind because this was an atypical melanoma.
Okay, sir.
Until you got the HPE, you were not very sure.
Yes, sir.
Well, thank you.
Thank you, sir.
What was the size of the tumor? Do you know the exact size of the tumor?
So it was 1.7 cross 1.3 cross 1.1. Definitely a larger size tumor according to COMS study, sir. According to COMS study, apical height more than 10 mm and basal diameter more than 16 is classified as large tumor, sir. So this categorizes under large tumor.
So it was just 1 millimeter more than your more than the COMS criteria.
Yes,
yeah. I think these days I've seen, from my Dr. Santosh Hanava's talk, I've seen that even such tumors are amenable to plaque brachytherapy, and that too when that's the only thing. Even the other eye is not okay. It has a macular scar, but yeah, that is an option. But yes, according to COMS criteria, this is the right treatment for this patient. And secondly, the ultrasound. I don't know, my first suspicion looked like melanoma in such a case because there was low internal reflectivity as it went. The wall was thicker and then it went lower. Acoustic shadowing you don't see in all patients. But yeah, for me, the first diagnosis was melanoma only. But yeah, very good, very well presented, very well documented. Even doing a HPE and all that was very well done. Thank you.
Okay, sir. Thank you, sir.
Tell me quickly about COMS study and the size-based division. What is small, medium, and large, and what are the managements?
So, according to COMS study, it can be categorized into three grades. First is the small, medium, and the large. Small is less than 2.5 mm apical height and less than 16 mm basal diameter. Medium is 2.5 to 10 mm basal height, apical height, and the basal diameter is less than 16 mm. Large is more than 10 mm apical height and more than 16 mm. More than 16 mm of basal diameter, sir. In that, small melanomas were just observed. They didn't do any intervention for it. And they look for the survival rate and the regrowth rates. And in medium melanomas, they were categorized into two groups. One group underwent plaque brachytherapy and the other group underwent enucleation, sir, and it was found that there was no significant difference between the two groups. And in large-sized choroidal melanomas, they were categorized into two groups. One group had underwent pre-enucleation radiotherapy, and the other group underwent only enucleation, and that also showed no difference between the two groups.
Okay, good. Very well presented.
Yes. Thank you, sir.
Nice presentation, Dr. Aishwarya.
Thank you,
now, Dr. Sindhuja, are you ready? Can you present now? You can stop sharing a slide, Dr. Aishwarya.
Yes,
sir. I think we are getting late for the next session. Dr. Sindhuja, can you present?
Can you present, please? Yeah, yes, she's on. Yes. You can start with the first slide, Doctor. You're on slide 3. Yes. Slideshow, please. Yes, you can start, Doctor. The time starts now. You can start.
Good evening, everyone. Am I audible now?
Yes, Doctor, you're audible. Yes, you can go ahead.
I'll be presenting 2 cases of atypical macular hole and surgical outcomes. First case is in macular hole in gyrate atrophy. A 30-year-old male patient complains of diminution of vision in left eye and night blindness for the past 4 months. Vision in left eye was hand movements close to face with PR accurate in all quadrants. Patient had elevated blood ornithine levels. This is the fundus picture of left eye. Here we can see retinal thinning with retinal detachment, which was noted in the posterior pole, along with the pucker temporally and a slit-shaped macular hole. And there was a diffuse chorioretinal atrophy along with bonus speckles. This is the pre-op OCT, which shows a full thickness macular hole. And the patient was taken for pars plana vitrectomy surgery. Initially, poor vitrectomy was done. Next, tricot-induced PVD induction was done, and BBG dye was injected to stain the ILM. And the PFCL was injected as there was a posterior pole retinal detachment to flatten it. And next, temporal pucker was removed. And again, under PFCL, again BBG dye was injected to stain more. And while removing, we could see an ERM along with it. First ERM removal was done. Even the ERM was placed near the hole, and later ILM peeling was done. FX was done, and the temporal at the site of pucker release, there was break noted, and it was laser. So post-operatively, at 5 months post-op, patient had type 1 closure of macular hole, and vision improved from finger counting to 1/60. Next case is a case of probable VK syndrome. The patient had complaints of diminution of vision in both eyes since 5 years, and patient was diagnosed outside as VKH and was treated with systemic steroids. He had vision of 636 in right eye and in left eye 660. This is a fundus photography. Here we can see full thickness macular hole and peripheral pigmentary changes and chorioretinal atrophy. This is a pre-op OCT which shows full thickness macular hole. Patient had vitrectomy was done with internal ILM peeling with 20% SF6 gas was injected. Intraoperatively, the ILM was thin and only partial ILM flap could be placed. Post-operatively, at 3 months, patient had vision gain
30 seconds, doctor. 30 seconds.
6/18 and a type 1 closure. So conclusion, though the pathology was slightly different from idiopathic macular hole, these cases also responded well with surgery, both anatomical and functional outcome. And these, if the in atypical macular hole, the hilum might be thin or it can be associated with epiretinal.
Time's up, doctor.
Dr. Sindhuja, good presentation. One question I want to ask is, what do you think must be the reason for the hole occurring in these two patients?
Yes, sir. First thing is, in both the case, it can be either due to cystoid degeneration at the macula, or in these cases, PVD induction occurs early, and this causes abrupt dehiscence of the at the fovea. There can be tissue dehiscence because of early induction of PVD. And other than that, in gyratrophy, because of retinal thinning, also all these are the pathologies.
If it's because of CME, what is the difference between both the CMEs in both the cases that you presented? Yeah, so ideally in your gyri atrophy, it must have been a non-leaking CME because of your this one retinal degeneration and all that. They must be the retinal barrier, blood retinal barrier breakdown, and that must have caused a non-leaking CME. Whereas in VKH, it must be a inflammatory CME, a leaking CME, which must have caused the CME and then the macule. Okay, good management.
Yes.
Over to the other judges.
Well presented, doctor. Nothing specific.
Thank you.
Was EOG done in the first case? I mean, like, how do you say that? Why was it taken up for the surgery? Because it was hand movement and there was so much degeneration. What was the justification?
Sir, actually, patient was one-eye patient. Here I mentioned only about the left eye, but right eye was tricycle eye, and for that reason only the patient had only finger counting close to face. And it was the patient also had a RD along with the macula hole, so we had to operate him.
Okay. Points taken. Good presentation. Yeah.
Thank you, sir.
Thank you, Nasik sir, Madan sir, and Obli sir. This comes to the end of session 3. Now we'll move on to session 4.
Thank you for the opportunity. See you.
Thank you very much, sir. So kind of you, sir.
Thank you, sir. Thank you all for the opportunity. Thank you, Tamil Nadu YOSI.
Thank all presenters enthusiastically they participated. Karthik, Pranesh, Prasanna, and TN YOSI. Thank you all. Thank you, my co-judges also.
Thank you, sir.
Thank you.
Thank you all. Thank you. Yeah.
Now we'll move to the next session, session 4, which will be on pediatric ophthalmology, strabismus, and neuro-ophthalmology. The judges for the session are Dr. Amma Pujari, Dr. Kavya Nidhi, and Dr. Deep Shekhar Das. I apologize to the judges due to the paucity of time. We'll just move ahead to the first participant. Is Dr. Bhavani there?
Yes, sir. Ready, sir.
Dr.
Can I share
Sindhya,
my
you have
screen?
to stop sharing your screen.
Yes.
We can see.
Yes.
Dr. Amar is.
Dr. Amar sir, Samar sir is there, Kavya ma'am is there.
Yeah.
Dr. Deep sir.
Yeah,
Yes, I'm here.
And Dr.
Yeah,
Amar
Deep sir
is my senior. He is my associate professor in AIMS, New Delhi. He is a specialist in pediatric ophthalmology, strabismus. And Dr. Kavya is a fellow in pediatric ophthalmology in strabismus. Dr. Deep, you have already introduced in the second session. Yeah, let's start with the first presentation. Dr. Bhavani here.
Yes, sir. I'm just sharing my screen. Can I start, sir?
Yes, doctor, you can start. You can start, Dr. Bhavani. Yes.
Okay. Hello, everybody. Today I will be presenting a case of left isolated pupil involving third nerve palsy with signs of aberrant regeneration. A 20-year-old male came to OPD with chief complaints of drooping of the left upper lid, binocular double vision, and outward deviation of the left eye for 7 months. He was apparently normal when he met with a road traffic accident. There was loss of consciousness for 1 day, bleeding from the ear and nose, and memory loss for 23 days. The left eye upper lid drooping was complete immediately following the trauma and gradually improved. Double vision is present binocularly and intermittently in up and down gaze. He has difficulty in moving his left eye inward. There was no history of diplopia in primary gaze, diminution of vision, difficulty in reading, diurnal variation of symptoms. No history of headache, nausea, vomiting, tinnitus, protrusion of eye or chemosis. No history of weakness of limbs, tremors, ataxia, weight loss, jaw claudication, scalp tenderness or fatigue. No history of any surgeries or laser, no history of any systemic comorbidities, and no significant family history. General examination, patient was conscious, cooperative, and moderately built, no abnormal head posture or facial asymmetry. On ocular examination, left exotropia, right eye extraocular muscle movements were full and free and painless. Left eye elevation depression was -4, adduction -1. Abduction and torsion was full and free and painless. Pseudo-Von Griffiths sign was present.
Right side.
And pseudo-Duane sign was present.
Left side. Okay.
Pupils, right eye was round, regular, reacting to light. Left eye was round but not reacting to light, reacting on convergence. Anisocoria present and pseudo-Argyll-Robertson pupil present. No reverse RAPD. Color vision, both eyes he was reading 21 plates. Best corrected visual acuity was right eye 6.5 and 6 at 30 centimeter. Left eye 6.6 and 18 at 20 centimeter. His cornea and facial sensation was intact. Slit lamp examination, right eye within normal limits, left eye mild ptosis. Both eyes intraocular pressure was 14 millimeter edgy. Ptosis evaluation revealed left eye mild ptosis with lag of ophthalmos and lid lag. Bell's phenomena was good in the right eye, left eye fair. Marcus-Gunn phenomena and Cogan's slit twitch was absent. Hertel's with a base of 100 was 16/16. Both eyes orbital margins intact. Squint evaluation also revealed a left exotropia. Left eye forced suction test for superior rectus and inferior rectus was negative. Birth 4-dot test revealed fusion to cross diplopia. Diplopia charting and Hess charting was done for the patient. His fundus examination revealed right eye within normal limits, left eye few vitreous floaters. So my diagnosis is left eye isolated pupil involving third nerve palsy, likely due to trauma. Both eyes HPF 30-2 was within normal limits. His recent MRI brain and orbit showed cisternal segment of the left third nerve not visualized and mild thinning of the left extraocular muscles supplied by the third nerve. The plan of action was nil squint intervention since patient did not complain of any diplopia in primary gaze. He's keen on ptosis correction, so he was advised left eye frontalis sling surgery under local anesthesia. Recent MRI brain was normal, hence no neuro-ophthalmology contraindication. So my take-home message is a complete and isolated pupil involving third nerve palsy is caused by an aneurysm unless proven otherwise. Hence, all patients with a new onset third nerve palsy require a CTA or an MRA brain. It is important to recognize aberrant regeneration of third nerve as this may be the only sign of an underlying space-occupying lesion or aneurysm. Microvascular disease usually causes relative or complete pupil-sparing third nerve palsy. Thank you.
Very well presented, Dr. Bhavani.
Thank you, sir.
Over to the judges. Amar sir.
Yeah, Dr. Bhavani, nice case presentation.
Thank you, sir.
So your take-home message is like we need to identify the aberrant regeneration at the earliest, so it might be harboring some sort of intracranial problem.
Yes, sir.
But as far as surgical management is concerned, you said that like you advise for left eye sling surgery.
Yes, sir. Because patient was he was keen on it for cosmetic purpose, and there was no intracranial space occupying lesion or aneurysm in this case. It was due to trauma. So since he wanted it for cosmetic purpose, we advised him for frontalis sling surgery.
But the Bell's is fair or like it's poor. So in those cases, patient will have definite risk of post-operative exposure keratopathy. Right?
So his ptosis was mild and he did not have any symptoms of exposure.
No. Post-sling surgery, because sling surgery is something which is going to tighten the lid, which won't allow any movement of the lid, right? So until unless you do the LPS plication, which is going to have some sort of down gaze, like, I mean, the upper lid is going to tilt down when he's looking down. There won't be any lid lag. But your like facial surgery or like any sort of sling surgery is going to be, it's going to be very scary. When patient looks down, the upper lid won't move at all. In this case, rather than like opting for left eye sling surgery, you would have advocated the right eye squint surgery, R&R.
Okay, sir.
In that that direction, you would have corrected the left eye exotropia as well as ptosis by doing the right eye R&R surgery.
Okay, sir. Okay, sir.
We do this routinely, so that's how you need to take advantage. So we never do like a ptosis surgery in third nerve palsy patients. At the end, if like ptosis is not getting recorded, we have to advise the stretch glasses.
Okay, sir.
Right. So that is like another scenario. But like by doing sling surgery in the left eye, so probably you are going to carry the risk of post-operative exposure keratopathy.
Okay.
So you can just pursue him for right eye squint surgery, R&R.
Okay. Okay,
Right?
sir. Okay, sir.
Thank you.
Okay, sir. Yes, sir. Thank you, sir.
Deep sir, Kavya ma'am.
Hello. Hi, Dr. Bhavani. It was a nice
Hi, sir.
presentation.
Thank you so much.
I just wanted to know what was the follow-up and what was the initial advice that you have given to this patient?
So initially, he had presented with complete ptosis. So that time he did not have complaints of diplopia. Then as his ptosis improved, he complained of diplopia. Then we had sent him for diplopia charting in his charting. And then we found that his diplopia was not present in primary gaze. And we asked him to follow up for 3 months. And he only complained of intermittent diplopia and up and down gaze. So we advised him to review every 3 months. And that's why we did not plan any squint intervention.
Okay, that justifies your this thing. Yeah.
Yes, sir.
But like I saw your the photographs that you have shown over
Yes, sir.
there, it did not look like that there was much ptosis in the left eye. It looked like,
Yes,
in fact,
sir. Yes, sir. That
like
was
it was
after
like
the.
retraction because of pseudo
Yes, sir.
retraction, possibly because of the abnormal innervation.
Yes, sir. That was 3 months, sir, later when he presented, sir.
In such scenarios, anyways, we are not going to plan for a ptosis surgery. Anyways,
Yes, sir.
otherwise,
Yes,
the
sir.
presentation was very nice.
Yes, thank you, sir.
Dr. Amar has covered most of the parts.
And one more suggestion, if you are saying it is a 3 months follow-up as of now, so you can
Yes,
just
sir.
like, because patient had diplopia, now he's not having diplopia. Probably
Yes,
he's
sir.
flushing intermittently. So that
Yes,
means
sir.
he is recovering, right?
Yes, sir. Yes,
So
sir.
as you said, like the SR and IR like limitation was -4, and for MR it was -1. So that means that MR is definitely getting some sort of like activity.
Yes,
You can
sir.
just follow up that patient for 6 months or even 9 months. So
Okay,
probably
sir.
just hope that like he's going to align himself and he's going to have very minimal doses, right?
Yes, sir.
So
Right,
the
sir.
nature will heal on itself. That is a
Yes,
good
sir.
option, right?
Okay,
So just
sir.
keep under observation. Thank you.
Okay, sir. Okay, sir.
Kavya ma'am? Kavya ma'am?
Dr. Kaveh, you're speaking, but you're muted. Please unmute
Okay,
yourself.
sorry. So very nice presentation. I just want to
Thank you,
ask,
ma'am.
suppose your patient had diplopia in the primary gaze, what all options you could have given?
We could have offered him patch therapy or occlusion of one eye, or maybe frosted spectacles in the other eye.
Which eye
Or,
patching?
sorry, sorry, sir.
Dr. Bhavani, which eye
Yes,
patching?
sir. So the uninvolved eye.
Why?
So that will eliminate the diplopia problem that he's having.
No, but left eye is exotropic. Left eye is supposed to be covered, right?
Yes,
Yeah.
sir. Sorry, sir. Yes, sir.
It has greater field of vision, doctor. So you have to see that.
Yes.
Okay.
Yes, sir.
And other than that, what you could have given, suppose say the diplopia would have been around 6 prisms or something. Just you would have measured and it would have been just that much. What you can give? What other things you can give? Other than patching, something else you can give?
Frosted spectacles.
Frosted
Or maybe
spectacles.
prism.
Same as patching, right?
Or prism spectacles. No.
Yeah. What prisms to use?
Fresnel prisms.
Yeah. Okay. Till what level of Fresnel prisms you can give? Like, can you give like a huge amount of Fresnel prism, or till what level can you give?
So basically, Dr. Kaveh is asking how much prism you can prescribe using Fresnel prism? 5 prism, 10 prism, 25 prisms. How much? What is the maximum limit?
5 to 6 prisms, sir.
That
Then
was
I-
with glass prism. That was with glass prism. With Fresnel, you can prescribe even up to 20 to 25 prisms also.
Okay,
You can just divide 12, 13, 12, 12 like that.
Hmm.
And one more thing, Bhavani, you said like right eye patching should be done, not the left eye. Because by patching the right eye, you are allowing the extraocular movement in the left eye. That's how MR is going to gain the function.
Yes, sir.
And the moment you patch in the right eye, what is the first thing you want to tell to the patient? Or else what is the like their like immediate problem, immediate concern they are going to approach you?
Their sir, their left eye will be exotropic. So medial field of vision will be restricted.
No, probably they are going to turn their head, or like they are going to do forceful adduction, so that under the patch right eye is going to have a large amount of exotropia. That won't mind. But the moment you patch the right eye and you are going to say patch with the right eye, you should be counseling them that like they are going to feel apprehended, they might feel giddiness, they might going to feel that like there is some sort of sweating. So they might feel apprehended. Ki bhai, ek aakh disi dikh raha hai. So that sort of complaints will be there. You need to caution them and try to begin with a small amount of patching, 1 hour, 2 hours, so they can extend, and ask them to move the left eye in all the gazes. Try to adduct the left eye. So that's how you are going to enforce the MR function regain, right?
Yes, sir.
I think we can move on to our next presenter, Dr. Prakriti Agnam. Dr. Prakriti will be presenting a case on emoji optic neuritis. Over to you, Dr. Prakriti.
Yes, sir. Good evening, all. Sir, I will be presenting through Dr. Komal's screen.
Just one second. Dr. Bhavani, you can stop
Yes,
sharing.
sir. Thank you for all the points, sir.
Thank you. Yes, Dr. Prakriti, you can
Yes.
share your slides. Yes, your
Are my
slides
slides visible, sir?
yes, slide shows on. Yeah, you can start presenting.
Good evening, all. Today I'm going to present a case of myelin oligodendrocyte optic neuritis. A 65-year-old female came to us with complaints of defective vision in both eyes, which is sudden, worsening over 3 days, more towards the left eye, with severe pain on ocular movements. On examination, her best corrected visual acuity was 6.9 in right eye and 6.36 in left eye. Color vision was reduced more towards the left eye. Pupils were sluggish with RAPD towards the left eye. Disc showed mildly elevated margins in the right eye and moderately elevated margins in the left eye. Other parameters were normal. Visual fields were very much depressed on both sides. A provisional diagnosis of optic neuritis was made. MRI brain contrast with orbits and spine screening was advised along with blood investigations. And on day 2, her vision dropped to 660 in right eye and CF 1 meter in left eye. Blood investigations were normal. MRI was suggestive of bilateral optic neuritis without any demyelinating lesions. So here we can see axial section of T1 post-contrast MRI, with which we see enhancement of both sides bilateral optic nerve. Long segment of optic nerve is involved, which is involving through the intracanalicular portion also, which enhancement of the perineural sheath. So IV dexamethasone 200 mg and 250 ml for 5 days was planned. By the end of pulse steroid therapy, her vision improved to 6.9 in right eye and 6.12 in left eye, with improvement of color vision also. Both eyes disc edema has also been resolved. At 1 week, her vision was 6.9 in right eye and 6.7.5 in left eye, with improvement in color vision. She was ordered a follow-up of 2 weeks, but came back after 1 week with sudden vision loss in right eye since 3 days with pain. Her visual acuity in right eye was PLPR inaccurate with RAPD and disc showing moderately elevated margins, while left eye is stable. Repeat MRI scan was ordered along with anti-MOG and anti-NMO antibodies. Sarcoidosis and syphilis workup was done and was normal. MRI showed recurrent acute optic neuritis in right eye with positive anti-MOG antibodies. 4 doses of intravenous methylprednisolone was given. By the end of pulse steroid therapy, visual recovery was suboptimal, that is counting fingers 2 meters. But disc edema has been resolved. She was referred to a neurologist for further management, where she underwent 5 doses of flex therapy on alternative days and was continued on oral steroids and azathioprine. So her final visual acuity was 6.9 in right eye and 6.6 in left eye, with good vision, color vision improvement, and also disc showed distinct margins. MOGAD is an antibody-mediated inflammatory demyelinating disorder of central nervous system. Optic neuritis is the common phenotype in adults, while ADEM is the common in children. Optic neuritis, most common age of presentation is 31 to 37 years, with young people presenting as unilateral and older people presenting with bilateral involvement. Visual prognosis is very good and many gain acuity of 20/20, but recurrence rates are reported to be 50 to 80% in various studies occurring from 1 month to 1 to 2 years after onset attack. Diagnosis is mainly by cell-based assays, which is the gold standard, source being the serum. Management, acute episode is managed through IVMP or pulse steroid therapy for 5 to 10 days. More severe and steroid unresponsive attacks are treated early with plasmapheresis or intravenous gamma globulin. So in MOGAD, mainly relapses are important because disability progression is relapse dependent, so maintenance therapy should be initiated. In many trials, relapses occur over 2 years, and risk of worsening increased after steroid discontinuation or dose reduction. Maintenance therapy is mainly by oral corticosteroids, slow taper over 6 to 8 weeks, or steroid-sparing agents, azathioprine, mycophenolate mofetil, or methotrexate. And in a case series, it was reported that immunosuppression for at least 3 months after first attack has been associated with reduced risk of relapse. So take-home message is MOG optic neuritis, though is devastating, it is treatable condition with good visual prognosis if treated timely and aggressively. It can occur in all age groups, and long segment involvement of optic nerve should raise a suspicion. Follow-ups are very important to timely manage relapses, and patient must be warned of symptoms, signs like pain and decrease in vision, and to come to us immediately after that. Thank you.
It was a nice case.
Thank you.
The thing is, one thing I want to ask is, like, a 65-year-old female is coming. So tomorrow you are going to sit in a clinic and a 65-year-old female comes. So what is the first date you want to keep?
With all this, with color vision decreasing and all, we'll be keeping any infectious pathologies or posterior scleritis.
No. I want your duties. I want like 4 to 5 duties. So 60, like you are going to face exam tomorrow. So
yes.
say for example, so the examiner will say that, like, tell me 5 conditions of 5 DDs. A 65-year-old female presenting with unilateral loss of vision. He might give the history of RAPD, or he may not tell that one. He might say disc, examine the disc, or he might say disc is normal or like slightly edematous. So what is the first DD you want to, assign at that particular age?
Multiple sclerosis or ischemic optic.
No, you should not be saying that one. You at like 65 years, you should be saying that like, I want to know the systemic history, diabetes or hypertension, and I want to assign the non-arthritic NA1, right?
Yes.
So then arthritic, because optic neuritis, as you rightly said in one of the slides, it is a mid-age problem, or it's like bimodal distribution. So as you rightly pointed out, 31 to 37 years. So at 65 years, nobody is going to suspect MOG or atypical optic neuritis. That is sort of like you do the MRI, like vision is not improving. Then suddenly the imaging finding pops up saying that there is a long segment optic nerve involvement is there. That is classical of MOG. So you manage the case very well. But in general, if you ask any person, they are not going to suspect MOG as the first entity.
Yes.
If that patient comes to my clinic, I'm going to suspect it is a probably non-arthritic or arthritic, ischemic optic neuropathy. Then probably I'm going to like, if it is not improved, then I'm going to evaluate. Yes,
because color vision was very much reduced and pain on ocular movements was specifically told by the patient, and she has no systemic history, so we have put it as first differential.
Yeah, those were the key signs you picked up, but otherwise in general, so we need to be keen. Need to keep all the exactly. So we need to keep all the DDs in our bucket list. So next time when you see the cases, just try to make at that particular. Say for example, if you get a 16-year-old female with unilateral painless loss of vision, she might be complaining of extraocular movement pain or may not be. So we are going to keep a checklist. Okay, it could be optic neuritis, it could be hereditary optic neuropathy, it could be like a male patient LHON. So that sort of like 4 to 5 DDs you are going to have. So that's how you learn. Also, that's how you are going to teach, and that's how it makes you to like rule out all the diseases in one patient. So if you have one patient, if you do like from beginning to end, if you do all the workup and if you keep all the DDs, you will learn so many things from one case itself.
Yes.
Thank you.
Thank
you.
Yeah, very nice presentation. So you have almost covered most of the things which we could have asked. But as sir said, like your age group is little not coming in the range of the normal presentation of MOG antibody. So I just want you to enlist few differentiating features between MOG antibody optic neuritis and multiple sclerosis and other types of optic neuritis. Can you just tell me the differentiating features like symptoms or some points?
Multiple sclerosis usually it affects more younger age group, while NMOSD it affects more compared to MOG slightly 30 to 40 years. While in multiple sclerosis, it will be more painless and unilateral involvement. While in MOG and NMOSD, there will be more bilateral involvement. And papillitis is more seen in MOG optic neuritis compared to multiple sclerosis. Multiple sclerosis, mainly retrobulbar neuritis is seen compared to MOG. And also coming to more rapid decrease in vision is seen in NMOSD, then MOG, and then multiple sclerosis. And visual prognosis will be more good in multiple MOG optic neuritis compared to both others. And
imaging, what area of the optic nerve is more involved in MOG, whereas what is more involved in multiple sclerosis?
MOG more retrobulbar, main intracanalicular involvement and long segment of optic nerve is involved. While in multiple sclerosis, the more anterior portion.
Right. Longitudinal enhancement, and what area is enhanced when you do
perineural and periorbital enhancement is also seen in MOG.
So basically perineural sheath is enhanced, okay, and whereas in multiple sclerosis what is involved mostly? So parenchyma of the nerve is involved, okay, so that will be the difference which you see in the imaging, right?
Yes.
Okay, that's all.
Thank you.
Sir.
Nice presentation. Most of the points have been already covered by the rest of the other two judges. So we can move on to the next slide as the next presentation. Okay. Yeah.
For the next presentation, we have Dr. Hemant, who will be presenting a case on arthritic AON as an initial presentation of Takayasu autoarthritis. Yes, doctor, you can share your slides.
Sir, are my slides seen?
Yes, doctor, your slides are visible. You can start your presentation.
Good evening, everyone. Now I'll be presenting a case of arthritic AON as an initial presentation of Takayasu aorta arteritis. A 34-year-old female who came with the chief complaints of sudden onset painful loss of vision in the left eye for the past 4 days, which was also associated with left-sided temporal headache for the past 2 days. And it was also associated with painful jaw movements on chain. And then there was no history of any limb weakness or bowel and bladder disturbances. And then she was only a known case of type 2 diabetes mellitus who was on only dietary control. And then she was not a known hypertensive or any CAD. Like on examination, general physical examination revealed significant pallor. And then the ocular examination of the right eye, vision in the right eye was 6/6, and the antral chamber had no evidence of any cells of flare, and then there was no evidence of neovascularization of iris. And then the pupils of the right eye were 3 mm, and then the direct reflex was brisk, whereas consensual was sluggish. And then IOP was within normal limit, and then the color vision and contrast sensitivity in the right eye was within normal limits. And then coming to ocular examination of the left eye, the vision in the left eye was finger counting close to face, and then the projection of rays were accurate, and then iris had no evidence of neovascularization of iris, and then the pupils revealed grade 3 RAPD, and then IOP was within normal limits, and then color vision and contrast sensitivity could not be elicited. And then coming to the posterior segment, right eye, the media was clear, disc was mildly hyperemic, and then the cup disc ratio was around 0.2:1, which revealed a disc at risk features, and then arteries to vein ratio was 2:4, and then there was minimal vascular venous dilatation and also tortuosity, and then the foveal reflex was sharp. And then coming to the left eye fundus examination, which revealed a pallid disc edema, and then the cup disc ratio could not be made out, and then there was associated venous dilatation, and then the foveal reflex was sharp. And then these are images of the fundus fluorescent angiography, which revealed left eye showed segmental filling defects of disc and the adjacent choroid, which was suggestive of Takayasu ischemic optic neuropathy. And then there were diffusely microaneurysms which was scattered throughout the fundus in both eyes, which was suggestive of Takayasu retinopathy. And then retrospectively, when we went and checked for the vitals, there was more than 10 mm Hg difference in between the upper limb and the lower limb blood pressure. And then on examination of the pulses, she had feeble bilateral radial pulses. And then coming to workup and the management, the ESR was elevated, and even CRP and then leukocyte count and the platelet count was elevated. And then on immunology workup, ENA and ANCA were found to be negative. And then MR angiogram confirmed the findings of Takayasu aorta arteritis. So actually the case was diagnosed as a case of Takayasu aorta arteritis and was started on high dose IV steroids, and then which was followed by a slow taper of oral steroid, and then the patient was maintained on immunomodulators. And then coming to the discussion, Takayasu arteritis is an idiopathic obstructive arteritis which involves mainly the large and the medium sized arteries, as this patient fulfills 3 out of the 6 criteria which were described by American College of Rheumatology. That is, age was less than 40 years, she had bilaterally feeble radial pulses, and then the difference of blood pressure in between upper limb and the lower limb was more than 10 mm Hg. So actually the main reason for this is the ocular hypoperfusion that may lead to the development of arteritic form of AON. So, and then the conclusion is it's always a great challenge to manage a case of Takayasu arteritis. So actually GCA is the primary cause of arteritic AON. So like even other rare cause of vasculitis like systemic lupus erythematosus and even the polyarteritis nodosa also should be kept in mind. So like any case of arteritic AON, in case of a young patient, it's always important to rule out all the forms of the above mentioned vasculitis. Thank you.
Hi, Dr. Hemant. That was a nice presentation.
Yes,
so one of the mentor is Dr. Shreyas.
Yes, sir.
Dr. Shreyas Temkar.
Yes, sir.
So he was my senior in RP Center, and he was the first person who showed me that like typical microaneurysm associated Takayasu arteritis. First time I saw. He was the retina SR. He showed me that for the first time. So we searched for those images on the Google, and we found similar images in the previously published article.
Yes, sir. Right? Now he is assistant professor here.
Yeah, I know. So what was the ultimate outcome in the left eye?
Like, sir, actually the patient ocularly actually she was improving, sir, but actually in a span of 2 weeks, actually she got systemically worsened, and then she had an attack of actually CVA, and then actually her systemic condition got worsened, and then actually we could not review the patient.
Okay.
The patient actually expired in a span of 2 weeks.
So otherwise, what did you learn from this case so that you want to apply for the next patient, right?
So like actually any case of like actually young patient who is coming with a future of arteritic AON, since actually arteritic AON usually occurs after the age of 65 to 70 years. So like any case of arteritic AON, like which is happening in the actually mid-age group. So like we have to consider like looking for even the systemic vasculitis. So like that should come to our mind.
So rather than you can put it like this. So you can say that like whenever you face a case of pallid disc edema.
Yes, sir.
You first like see that and verify that and show it to everyone, right?
Yes,
so because that is very unique and rare finding, whatever the findings you got, and the other eye disc at risk.
Yes,
so in those cases, when you're expecting tachyarteritis because of the choroidal non-filling around the disc and like microaneurysms, you should go for like neck Doppler also, right? So you need to, look for the luminal opening of the vertebral and the intercalated artery, because probably if you have like done a Doppler neck, you would have said that like she's going to develop, cerebral vascular accident. You would have predicted that. And in future, if you are going to get these sort of patients, you need to do the neck Doppler so that one eye is gone. So anything you do, that patient is not going to improve in the left eye.
Left eye, yes, sir.
Say for example, you get this sort of patient in future. So at least you can do something on the right side.
Right eye, yes, sir.
Right. So there are so many neurosurgical advancements in it. You can refer the patient to endovascular surgeon, and you can do something in the right side so that you can prevent ocular perfusion syndrome in the right eye. Nice.
Yes, yes, sir. Okay, sir.
That is learning point.
Okay, sir.
Yeah, nice.
Thank you, sir.
Thank you.
Thank you, sir.
Well presented, Dr. Hemant.
Thank you, ma'am.
Do you know the stages of Takayasu retinopathy? Can you just tell me?
Like, yes, ma'am. There are actually 4 stages. First stage is actually dilatation of the small vessels. And then the second stage is actually microaneurysm stage. And then the third stage is like venous anastomosis. And then the 4th stage is ocular ischemic syndrome.
Okay, what will be the features of ocular ischemic syndrome?
Yeah, ma'am.
What will be the features in ocular ischemic syndrome?
Like actually ocular ischemic syndrome, actually the patient might, when we go to anterior segment, the patient might have actually limbus to limbus corneal edema. And then the patient also might have actually asymmetric diabetic retinopathy features. Like if it's like a non-diabetic.
So basically, rubeosis iridis can be there, neovascularization, then it can proceed to VH also. Okay.
Okay, ma'am.
Okay.
I just wanted to know, how did the patient initially respond to the steroids, or it was the same? Was there any increase or improvement in the vision?
The vision did not improve, sir, but actually the disc edema was resolving actually. But actually the vision remained the same, sir. Actually, finger coating close to face was the vision even at the end of 2 weeks.
Was that initially you started the patient on 3 days pulse therapy and then oral steroids.
Yes, sir. Yes, sir.
And the patient passed away. That's what you said. You're saying.
Like
right?
After 2 weeks, the patient passed away. Yes, sir.
What was the cause of death? Was anything found out, or the patient was, because the patient turned unstable, you shifted to other department? I just wanted to know. Like,
yes, sir. Actually, for its actually systemic management, we had actually transferred out the patient for actually medicine, and then actually the patient had likely I'm not sure like exactly what.
Okay, let it be. I just wanted to know if if there was any obvious response or not, and we could have worked about what kind of management.
Vision wise, the patient did not show any response, sir.
Okay, fine. We can move on to the next condition.
Thank you, sir.
Thank you, judges. Now we'll move on to our next presenter, Dr. Anjana. Dr. Anjana will be presenting a case on mirror image esotropia in monozygotic twins. Dr. Anjana, yes.
Sir, can you see my slides?
Yes, doctor. Yes, your slides are visible.
A very good evening, everyone. This is Anjana R, junior resident in Dr. Apte Center for Ophthalmic Sciences. I am going to present a case on mirror image esotropia in monozygotic twins. These are my headings. A 20-year-old male monozygotic twins came to outpatient department of Dr. Apte Center with complaints of inward deviation of left eye in twin and inward deviation of right eye in twin. They were basically brothers who had similar complaints, so they came to Apte Center for the further evaluation. There was no history of usage of glasses, no history of double vision, no history of any eye ointment usage or patching, and no history of any ocular symptoms. Their past history was no significant. Birth history, they were termed NVD, tried immediately after birth, but they were monozygotic twins. There were no significant family history or personal history. So we went for detailed ophthalmic examination where the twin one had a visual acuity of 6/6 in right eye and 2/60 in the left eye. This twin two had finger counting at half meter in the right eye, that is 6/6 in the left eye. And dioptry was normal, anterior segment was normal. Extraocular movement, they had mild limitation of LR in left eye in twin one and right eye in twin two. So we went for a strabismic evaluation where we could see which was there was 30° in twin one and 20° in twin two. So we did a Krimsky for them. It showed 75 diopters base out for twin one and 70 in twin two. And test of binocularity and periopsis showed left eye subtraction in twin one and right eye subtraction in twin two. So we did a refraction as a part of strabismic evaluation where we could actually find the twin one who had a left convergence point had plus 2.5 astigmatism at 180°, whereas the twin two who had a right convergence point had plus 2.5 degrees cylinder at 90°. So this was corroborating with the delta K values in IOL. So here, this is a clinical picture of the twin one who is showing the left convergence point and twin two who is showing the right convergence point. So we planned for a surgery because they wanted a cosmetic correction. So twin one underwent left eye MR recession and LR correction, whereas twin two underwent right eye MR recession and LR correction. Intraoperative and post-operative period was uneventful. So in post-operatively, you can see both of them have developed so what I want to conclude with this case is this was quite interesting because twins came to us with similar complaints, and we went back and did a literature review where we could find this interesting phenomenon called as mirror imaging, which is also known as biological polarization, which is observed frequently in monozygotic twins. It is due to late cleavage of zygote. That is, normally the zygote cleavage occurs in 7 to 8 days. When it occurs a little late by 1 day, there is a blockade of distribution of predetermined and homeobox genes, which specifically affects the ectodermally derived genes. Like this mirror imaging has been reported in mirror imaging in dentition, mirror imaging in arachnoid cyst, but ophthalmic manifestations were quite rare. So we wanted to highlight one such manifestation we observed in our OPD. And another interesting phenomenon we read through the article is when such twins develop mirror imaging, they also have a mirroring of handedness. So we went back then checked, we could actually found like the twin one who had a left convergence point was left-handed, and the twin two was having right convergence point was right-handed. This I actually observed when I was taking consent for the surgery. The twin one was signing in left hand and the twin two was signing in right hand. And we went back and studied, we could actually found this correlation. So this is just a highlight of mirror imaging which has been observed in a common day-to-day practice. Then we come across a lot of videos of this. It was quite different. So we wish to highlight this manifestation. And these are my references. And from India, I could not find anything. But abroad, Dr. Dirani had done a quite amount of research, and he has published mirror imaging in esotropia, as well as in myopic astigmatism, as well as in head tilt with nystagmus in monozygotic. So these are my references, and thank you.
Thank you, Anjana. Nice presentation. So what is the one key point or take-home message you want to highlight here?
So basically, we come across a lot of esotropia. So basically, history taking is very important. Like we could actually find it out because we usually do a pedigree chart, and while doing the pedigree chart, these beds were admitted side by side. And they're telling he's my brother, and do the pedigree chart, we were actually marking both of them as case. And we were like, why is this happening? Like if twins having same problem but at different times. That actually segment. So I feel taking a proper history and taking a proper family history plays a major role, and we could actually gives the scope of opening up of genetics and refractive errors and so I feel that is this case gave me that I should be more careful in history taking. This enlightened me.
So you did surgery and you improved the deviation. You made orthopedic.
Yes, the deviation was the patient gained orthopedic.
Yeah, but rather than surgery, you need to highlight that, like, and put it in this manner, saying that, like, in future, whenever you encounter any monozygotic twins, so you need to say that, like, let them undergo ophthalmic evaluation. So it could be that they had like more than 2.5 diopter cylinder in the like early period to begin with, probably 4 diopter or like 1.3 diopter. That led to, I mean, like blurring of the retinal image. That's why they tried to accommodate, or like they just ignored the image. That's why they ended up with esotropia, and esotropia is more amblyopia compared to exotropia. So in future, we can like say like this. So whenever you encounter any sort of twins, so let them undergo ophthalmic evaluation, because they might be having some sort of findings which could be significant. So if you are going to educate the public in future saying that monozygotic twins should be like screened for ophthalmic findings, so they can undergo refractive error, and you can just improve the vision. That is the first point. So if you improve the vision, the strabismus may not develop at all. Right? So rather, we want to educate the public saying that it is better that the twin should undergo ophthalmic evaluation. Let them wear the glasses, and if at all they need surgery, we can do surgery at any point of time. But vision is precious. We should have improved the vision if they would have come early at the age of like 1 year or 2 years. Thank you.
So Dr. Anjana, interesting case. You have presented a very interesting case. So I just want to ask you one question. It is in continuation with what Dr. Amber asked. So just let me know, like, do you know the difference between operating early or versus late for infantile esotropia? Like your patients had esotropia from birth, is what you said.
No, actually, in esotropias, infantile esotropias, we do a proper cycloplegic refraction, and we prescribe them with glasses. And if the
no, like I want to know whether we should operate early or late. Like, what are the advantage and disadvantage of operating infantile esotropia early versus operating infantile esotropia late?
We have to operate infantile esotropias early. The thing is, but before that, we have to give a full cycloplegic refractive correction, and then we have to operate them.
Okay, what I mean to say is you are treating amblyopia and then you are operating. That way you are coming to say, right? Glasses treatment. So
The thing is, what I would feel is if we operate the esotropia first, if the deviation goes, then the patient, the follow-up with the amblyopia management and glasses won't be, properly followed by the parents. So I would feel it should be properly corrected, educated, and it should be operated.
Okay. So basically what I wanted to emphasize is, like, if you operate infantile esotropia early, what you're doing is you can still preserve the stereopsis of the child. Okay, stereopsis, and then you can continue with the amblyopia therapy, because esotropia, infantile esotropia is associated with amblyopia in 40% cases. Okay, and whereas in early cases, like a very young child, if you have a very young child of infantile esotropia, like 6-month-old or 8 months old, the finding the angle of deviation is a little difficult task. It is a challenging task. Moreover, the eyeball is small. So even the small amount of corrections may lead to overcorrection also sometimes. So that is one disadvantage of doing early surgery. But advantages, you can preserve the stereopsis, you can treat the amblyopia therapy. Of course, in our population, the thing is patients think that once they are operated, everything is cured, as you said. So they might not adhere to the amblyopia treatment therapy. That is right. And if you are operating late, what is the benefit you are getting is your angle has become constant. It is not changing anymore. You know what is the measurement. So more chances are there that you would give a like orthophoric eye after the correction. Okay. So that's what I wanted to ask. Thank you.
Hi, Dr. Anjana. This is Dr. Deep here. Am I audible?
Yes.
Hello. Yeah.
Yes,
Am I audible? You kept on saying one thing, that you have to correct the refractive error. And ma'am kept on saying that it's a case of infantile esotropia. How frequently is infantile esotropia associated with refractive error?
Sir, they are associated. Like infantile esotropias, they are associated with refractive error. That's why we always
that is a very broad statement. Tell me one diagnostic feature of infantile esotropia. Did you check in your patient?
As they will have alternate fixation.
That is cross fixation. That is the word you need to use. What is the examination finding you want to say? What is the examination finding you want to elicit?
Patient will have cross fixation in infantile eso along with.
Yes. So if they had cross fixation, they are going to maintain equal vision in both the eyes. They are not going to manifest with one eye. So it's unlikely that it could be infantile esotropia. Second thing is, you need to check for pursuit asymmetry. If pursuit asymmetry is there, then it is again more diagnostic of infantile esotropia. We can read all the theories related to monkeys and human beings. Lawrence Tyson has done a lot of work on that one. You can read that one. So Dr. Deep want to emphasize that there are two things. Infantile esotropes are going to be, often they are going to be cross fixators. So that's why they are not going to have any loss of vision in one eye. And they are going to have pursuit asymmetry. That's why they are going to maintain the binocular vision, 6/6. So you can operate at any given point of time. As Dr. Kavya was saying, you can do it early at the age of 6 months or like even 8 months, 9 months, just to maintain the stray optic. There are evidence to show that. But your case is unlikely fitting into infantile esotropia, provided.
Not a case of infantile esotropia. It's just that whenever the twins split gate, there is a chance that a patient might have asymmetric, like in the refractive, it might lead to esotropia in one eye. It could have been easily prevented by giving a proper refractive prescription at an early age and advising for refraction in children. Basically, school refractive screenings would have easily picked up them and they would have saved vision in one.
That is the key.
Very interesting situation. Yeah, it's very rare. Like I've never seen till now mirror imaging per se.
Yes.
Anjana, last question. I think you've already done the literature review. Internationally, how many cases have been reported till date?
There is one person
I
called
wanted to know for
Dirani.
my curiosity. I don't know much about it myself.
From India, it has not been reported till now.
Outside?
Outside, there is one person called Dirani who has published 4 series of
4 series.
four cases. Basically.
Think about publishing this one.
One case from Japan has been, Korea has been reported.
Okay. Thank you. We can move on to the next presentation.
So over to the next presenter, Dr. Mridula Vijayaraghavan. She'll be presenting a case on acquired esotropia, the wonder of Botox. So Mridula, you can share your slides. Your slides are visible.
Am I audible?
Yes, you're audible.
Are my slides visible?
Yes, you can start your presentation.
Good evening to one and all. I am Dr. Mridula Vijayaraghavan from Shankar Nethralaya, Chennai. I'm presenting an interesting case about the wonders of Botox in acquired esotropia. So we will be looking at the case in the following headings. So what is acute acquired concomitant esotropia? It has an acute onset. It is the same in all directions of gaze with a normal extraocular motility. Some of the causes include visual deprivation, refractive error, neurological abnormality, and the highlight of our talk, which is excessive near work. That is an increased screen time, which we have drastically seen in the COVID-19 pandemic. So we have a choice of treatment between Botox and strabismus surgery. So coming to our case, we saw a 7-year-old girl who had sudden onset inward deviation of both eyes along with double vision since 8 months. And she used her smartphone for around 6.5 hours every day. On clinical examination, both eyes had a best corrected visual acuity of 6/6 N6 with and without glasses, with a cycloplegic refraction of +1 diopter spherical. Stereopsis was 40 arc-second, and extraocular motility was full and free. And on prism bar cover test for distance and near, there was 35 prism diopter comitant esotropia. On red filter test, there was uncrossed diplopia, and the rest of the examination, including cranial nerves, anterior and posterior segment, was within normal limits. So we came to a working diagnosis of acute acquired comitant esotropia. Some investigations like the MRI, brain, and orthotic workup was perfectly normal, and old photos confirmed the history. We gave the child a trial of prisms, but the child was not comfortable. And on atrophy and refraction, there was no change in hyperopia. The intraoperative forced suction test came negative. So why would we use Botox to manage this case? Because it's convenient, simple, cost-effective, and there's minimal trauma and pain, and the outcomes are comparable to surgical correction. Why would we choose to do surgery? It is useful in cases of long-standing cases with large angle deviations. And also we must remember that the effect of Botox is temporary. So we gave 3.5 international units of Botox in both eyes medial rectus muscle. So here we have a video wherein we made a fornicial nick in the conjunctiva, following which with a muscle hook, the medial rectus muscle was hooked, and then we retracted the conjunctiva with the other muscle hook, following which 3.5 international units of Botox was taken in a tuberculin syringe and with a 30 gauge needle, it was injected directly in the muscle belly. So here we have the child pre-operatively and post-Botox injection, where she was orthotropic and continued to remain so at the 4-month follow-up. We know that increased screen time can cause ocular and systemic adverse effects, like ocular, including acute acquired comitant esotropia and digital eye strain, and systemic, like stress and anxiety. So the clinical pearls which I would like to stress on are the screen time should be reduced, and increase screen time and excessive near vision can produce AAC. Botox injection can be used as a successful alternative to surgery, and lifestyle modifications need to be encouraged in children. Thank you.
Komal, you can mute your Komal. Dr. Komal, please.
Only sisters who are there, you see. Others don't come.
Dr. Komal, please mute yourself, please, doctor.
Yeah, Dr. Mridula, nice case presentation. So what happened after 4 months?
Sir, actually, presently the child is at the 4th month follow-up.
So what do you expect after 4 months? Say
Sir, since the effect of Botox is temporary, we can expect that the deviation will recur. But sir, actually there is Botox injection has an effect as well as an after effect. So there have been cases where the deviation has not recurred for a while following the Botox injection as well, sir.
So was your case having diplopia?
Yes, sir. There was double vision.
So it was acute comitant esotropia then?
Yeah, yes.
So did you do imaging?
Yes, sir. MRI brain was done. It was within normal limits, sir.
It was normal.
Yes, sir.
Okay. And you were hooking the muscle with the lens hook, and you said you are hooking the muscle with the muscle hook.
So it is the small muscle hook.
It is neither Jensen's or Green's. It is lens hook, I feel. Okay, you can introspect the video once again. So thank you.
Yes, thank you, sir.
Okay.
Dr. Mridula,
Yes,
tell me the effect of botulinum toxin will peak after how many days? Like you have injected and the very next day, do you find the child to be ortho, or how is it?
Yes, ma'am. Actually, I myself have seen some cases of AACE wherein on the next day itself the child was orthotropic.
Okay, like even I have seen cases like we have been doing in Arvind Eye Hospital when I was working there. So
Yes.
usually it peaks at 14 days. So
Yes.
call the patient for a next day follow-up. It is a daycare kind of procedure. Like until like this patient, of course, you have given general anesthesia. That is a different thing.
Yes.
So that to like recover back from anesthesia. But otherwise, you discharge the patient and you can just call comfortably after a week or so. Because
Yes,
the peak effect usually comes in 14 days.
14 days, yes.
Also, do you know what is the lethal dose of Botox? Because you're injecting something, so you must know that, right?
Ma'am, more than, I am not sure, ma'am. I think more than 50 units.
No, it's like unit wise, it's basically like 0.09 to 0.15 microgram. Okay. And
Okay.
what the vial which we get is basically 100 units of Botox.
Yes,
and that contains very minimal, like 0.00073 micrograms. Okay.
Okay, ma'am.
So very crisp presentation. I liked your presentation. Good.
Thank you. Thank you, ma'am. Thank you.
Now moving on to the next
Thank you, ma'am.
last,
Thank you, sir.
Thank you.
last participant, Dr. Shastika. Are you there, Dr. Shastika?
Shall I start, sir?
Yeah, Dr. Mridula, you can stop your slide share, doctor.
I couldn't share my screen, sir.
One second. Dr. Mridula, you can stop sharing your slides.
She went.
1 minute, sir.
No issues. Yes, doctor. Shastika, you can share now. Yes. Yes, doctor, you can start now.
This is Shastika, postgraduate from Government Salem Medical College, presenting an interesting case of bilateral proptosis. 11-year-old female child. She was brought by her parents with chief complaints of swelling in both the eyes for past 5 days, with associated history of swelling in the right cheek and left cheek for past 1 week, with history of redness in the both eyes for past 4 days, and history of bleeding of nose for past 2 days. No other significant family or past history. On general examination, the child was very irritable, febrile, and bilateral submandibular lymphadenopathy was there. General systemic examination of CVS, RS, CNS, and perabdomen was normal. Moving on to local examination of right cheek, she had a swelling of size 4 into 3 centimeter, which was stony hard in consistency. In left cheek, we could see a swelling of size 2 into 3 centimeter, which was non-tender. On ocular examination, her both eyeballs were very tense. Periorbital edema, SAH, congestion, chemosis was there. Cornea was clear in right eye, and left eye had inferior exposure keratopathy. AC was quiet, pupil was reacting to light, lens was clear, EOM was mildly restricted due to chemosis. On fundus examination, we could see disc margins were blurred, edematous disc, and superficial hemorrhages were present around the disc. Veins were tortuous, macula was normal. B-scan orbit was done, which was normal steady. Moving on to CT facial bone with brain, it showed a soft tissue thickening in both superior and extracorneal space, causing proptosis. MRI brain of right orbit showed preseptal and periorbital soft tissue thickening in both corneal and extracorneal space, and there was no focal lesion in the brain parenchyma. MR angiogram showed no aneurysm or AV malformations. In MR venogram, there was no thrombosis. So we narrowed down our diagnosis and proceeded with the blood investigations. As we suspected, she was anemic, and there was leukopenia, thrombocytopenia, and thrombocytosis. CRP was elevated, RFT and LFT was within normal limits, USG abdomen was normal. Peripheral blood smear was done, which showed myeloblast cells. So flow cytometry was proceeded, in which it showed acute myelogenous leukemia with maturation, which was suggestive of acute myeloid leukemia. So with all the above investigations, we confirmed it as a case of acute myeloblastic leukemia with the maturation M2, which is a subtype of acute myeloid leukemia. So as discussion, AML is a clonal expansion of myeloblast cells in bone marrow. Thus, rapid growth of this abnormal proliferation of the cells, it will interfere with the normal blood cell production, leading to acute myeloid leukemia. This is the image of the child after 4 to 6 cycles of chemotherapy. The time of our presentation to us, the workup we did, the diagnosis and the referral, all these occurred within less than of 24 hours. She was immediately started with treatment of chemotherapy with induction phase of doxorubicin and cytarabine and maintenance phase of cytarabine. So the incidence of AML is about 15%. In which 3% they develop granulocytic orbital sarcoma or chloroma. So an AML can initially present with orbital involvement even without the clinical presentation of AML, underlying leukemia. So I present this case for its rarity. As an ophthalmologist, as early as we diagnose these cases, we will make wonders. And so any child who is presenting to us with orbital mass of uncertain origin, particularly if it is bilateral orbital involvement, we should always undergo prompt evaluation for AML. So in this pediatric age group, we should always do a peripheral blood smear and image workup. Thank you all.
Nicely managed case, Ashtika. So before proceeding to bilateral proptosis, any case of bilateral proptosis, it's a very, unique case, or it's a life-threatening condition, as I said. So what are the DDs you want to keep before proceeding to any sort of investigation?
Yes,
you need to examine from lid till the optic disc or the retina. Then you need to make your DD. So what was your first DD?
Metastatic neuroblastoma or inflammatory orbital diseases.
Neuroblastoma, it presents more of panda eyes, right? So it is going to have subcutaneous bleed. So it's not going to have that sort of severe proptosis. Okay, you can keep second DD.
Cavernous thrombosis.
Exactly, that is the important point. So in a kid, you are going to keep neuroblastoma as the first DD, but cavernous sinus thrombosis is very important because there could be a danger area face which might be infected. There could be pimple, there could be a skin scar, the scalp is like very, vascular. So you need to look out for the cavernous sinus because it needs to intervene at the earliest, right? Okay, third one.
Sir, lymphangioma or orbital extension of.
So what could be typical history of lymphangioma? Often they will have unilateral, but if they are bilateral, unfortunately.
Sir, upper eyelid swelling will be there.
No, like lymphangiomas will have acute bleed inside the lymphatic cavities. So prior to that, they are going to have history of URI or fever.
Respiratory tract
Exactly.
infection.
Yes. Okay. Third DD.
Bilateral optic nerve glioma.
Could be. That is very rare. Again, could be.
Rhabdomyosarcoma.
Could be, but again, that is going to be unilateral, right?
Orbital cellulitis, but it will be afebrile. This
Yes,
child was
orbital cellulitis with cavernous sinus thrombosis or cavernous sinus involvement. That can present with bilateral. And when you showed the disc finding and the retinal findings, why there were like retinal hemorrhages? Were there any retinal hemorrhages?
only superficial hemorrhages were there, sir.
Why they were there? Did that mean something to you? Sorry?
Only around the disc it was there, sir.
Why they were there? Like you need to take that as a sign just to explore what is the cause.
Because of leukemic infiltrates of the orbital cells.
No, there is something, some entity called, you can go into the literature and you can learn or read. There is a leukemia associated optic neuropathy. So you need to tell the patient that like leukemia can recur with optic nerve infiltration also in future, even though she has gone into remission. So you can look into literature, you'll get a lot of reports where like remission has happened in the optic nerve, nowhere in the body, right? And because of these leukemic cells which are going to infiltrate the bone marrow, there's going to be associated anemia. So it's an anemic retinopathy, which you are having retinal as a hemorrhage, right? So you need to understand that like what are the things which are happening behind the curtain, right? So when you connect these dots, you are going to learn a lot and you are going to see patient from a different perspective, right? Thank you. Thank you.
I think everything is covered by Dr. Amar sir and well presented, doctor. So I'll just pass.
Yeah, it's a very nice presentation.
Thank you, sir.
I think we can move on. Yeah.
Thank you very much, judges. This marks the end of session 4.
Yeah.
And we have completed the prelims for Noi Naadi. So as Karthik has promised, he said there will be a knowledge pouring out through the judges' discussion. Actually, I'm not able to contain the knowledge in my head. Actually, exceptionally, it was really nice to be a part and amazing input from the judges. I really thank Dr. Amar, Dr. Deep, and Kavya ma'am for their presence in the session 4, and all the judges for the wonderful participation, and for the participants for sticking on time and taking part in this event. Dr. Karthik has finalized.
Just a minute. Okay, first I'll thank Dr. Amar sir and Dr. Kavya and Dr. Deep for being a wonderful session with wonderful discussion. Now we'll hand over it to Dr. Karan, the Secretary of Young Ophthalmological Society of India. Welcome, sir.
Thank you, Dr. Karthik, Dr. Ravi, Deep, and Kavya, everyone. Thank you.
Thank you, everyone. Thank you.
Thank you, organizers, and thank you, my co-judges.
Yeah, thank you.
Thanks.
So thank you all. Thank you for the organizers. I would say a wonderful program. Karthikeyan, Niranjan, Pranesh, and Prasanna, who've done an excellent job in this, and a big kudos to the judges also, because it's not easy, judging, and an excellent program, a good session of the prelims, and all the best for the finals, I'll say. So I'll just be making a short presentation. Is my screen visible?
Yes, Karan, it's visible.
Yeah. So it's basically, what does YOSI do for young ophthalmologists? So I'll try to run it short. So basically, YOSI started off, in 2014 under the able leadership of Dr. Tarun Arora and Dr. Vijay Sharma. And it started off basically as a Facebook group to promote basically with the focus being towards residency, fellowship, and the first 5 years of practice. Yeah. So what is YOSI? We are a registered society with the All India Ophthalmological Society and the International Council of Ophthalmology. We cater exclusively to the needs of ophthalmologists in training or under the age of 40. And we want to act as a bridge between senior leaders and young ophthalmologists and positively impact the lives of these young eye surgeons.
So this is how it started off as a Facebook group. And if you can see over here, there was help regarding, sharing knowledge, thesis, case presentations, exam help, some fellowship discussions, some updates, even the wins were celebrated, and everybody used to encourage each other. So after the old guard, the new guard that took over in 2018 was this one. And this was the first AIOS YOSI forum that we had. And this team actually led the put basically the foundation stone on what YOSI was to do in the next couple of years. So basically, we have an election process, and there's no repeat of the governing council post, and elections occur every 2 yearly. So this is the current governing council, where Sonal Kalia is the president, Dr. Digvijay Singh is the immediate past president, Devakant Mishra is the vice president, I am the secretary, Avanish Upadhyay is the treasurer, and Nilesh Kumar is the joint secretary. We also have 20 executive members, and basically 2 of them are the ones who have organized, Prasanna and Karthikeyan, who are one of the organizing the team for this Noi Naadi competition. So we started off with the new team, the one that came into effect in a year back. We put up some presidential working group support, where it was the membership drive, the website with Prasanna is leading. The state chapters were there. We had a legal cell, the Yo Times, which was a time-old thing, the YOSI slides, the fellowship help desk, the journal club, a couple of programs such as the Surfing the Anterior segment, where anterior segment cases was discussed, including oculoplasty, late night retina, a job portal, support for travels and conferences. We are working on that. Social media, there was a residence network as well, flash notes. We have our own YouTube channel, which we launched in 2018, record keeping department, and a social cultural team as well. So we've got a couple of state chapters as well. And this was the first DOS YOSI session that took place in 2014. This was the first issue of our journal, that is the Yo Times. We also do an annual AIOS YOSI writing competition, and this was the one in 2019. This was the esteemed panel of judges, which including international ones like Dr. Subur Huang, who gave their time, to judge. We also do this YOSI quiz was conducted in 2019 with about 200 participants, and the first prize was around $1,500 US. During the COVID also, we were active and we did a quiz. This was a completely online, which was read by Sonal. So from 2019 onwards, we are having a separate spot, a separate hall in all the AIOS conferences. This is known as the Yo Pavilion. Like internationally, you have the Yo Lounge, we have the Yo Pavilion over here. And this was inaugurated in 2019 by the then ICO chief. So in these programs, we had, all the programs were decided, and everything was done by the YOSI team and not by the AIOS. And AIOS, we are greatly thankful to AIOS for giving us full support in all of this. So this Yo Pavilion was there, which opened every day from 9 a.m. to 6 p.m. and it was exclusively for the Yos and by the Yos. We do this young ophthalmologist retina case competition as well, which is known as the York. This was the oculoplasty and oncology case competition. So we do a unique program known as the Meet the Mentors, where the residents interacted with the fellowship directors and the representatives of major ophthalmic institutes and heard them about their residency and their fellowship program. This is the one from 2019. You can see leading institutes have participated, and these institute heads are now on the hot seat, and we are the ones who are asking the questions. Basic questions like, what do you want in a CV? What do you see in an interview? What do you see in a candidate? Why are you not giving stipend? Why is the stipend less? We asked all those hot questions to them, and they gave the answers. We have also conducted the YOSI hackathon. There was one which occurred in Pune just about a couple of days back as well, in association with MOS. We also do a Q&A with ophthalmic innovators. This is the surgical video competition for the anterior segment that we also do. So this was the Yo Pavilion at AIOC 2022, where we had 118 Yo faculty. I repeat, 118 Yo faculty. And who were these faculty? They were residents, fellows, and consultants. It is not easy to get a faculty post in a national conference, and we make it our way that we try to help them so that it acts as a bridge and get them the podium post, because we have a big pool of talented youngsters out there. This also included keynote talks by Dr. Suvan Bhattacharya ji, Sabyasachi Sengupta, and Pranesh Balasubramanian. We had a surgical anterior video competition there as well. We had some training sessions as well on residency, on fellowship programs. We had sessions on finance and practice management. A lot of good feedbacks were here, which were given by other YOs about the program. So this was the session in AISC 2019. This is another main session that we do apart from the YO Pavilion. This was in 2020. And this is in 2021. I'll just breeze through these. So you can see, different people are involved. The panel may remain the governing council, but we try to include different speakers at different times, even in these sessions, and give them opportunities. So we have a session this time also in the IOS, and we've sent it as an invited session. This was at IFOCA 2019. So we've participated in various conferences across India and internationally as well. These are some of the pictures of those conferences. We also do this ophthalmic wars in the theme of I'll just skip to this. So this was like a and it's more of a fun event that we've been doing since 2018. This was the pictures of the AIS-YOSI Forum 2018, and this was basically focused on acing the ophthalmology residency program, maximizing the fellowship. What are research and publication and management sessions for the U's as well. We had some international faculty, and this was basically in collaboration with the Singapore Society of Ophthalmology. These are some pictures of that. This was the program. We've also gone international and participated in various international sessions. We've had some international interviews as well, particularly by the Cake and the Pie magazines. So one of the big advantages that YOSI gives is also networking with international YOs, and it creates a bond also, and we help each other out. This is also, we've also helped and partnered with other YO societies. This is left one is from Danish. The other one is from Jordan, from Bangladesh. We've connected with various societies, and we do have regular meetings with them. As of 2020, we also became a member of ICO. This is what our Facebook page looks like. We have an Instagram account known as YO Society India. This is the Yo Times one. This on the right, you can see this is the latest edition of it. This was the launch of the 13th issue. This 15th issue this was the single go-to source for all VR aspirants and all young VR surgeons. We are working on similar things as well. We have our own YouTube channel where we put all our webinars. Even this one is going live on it. We have also have interviews by different people. This is senior ophthalmologists who help us guide as well. This video of mine has actually got more than 52,000 views, and it's extremely important. Even basics are important. This is flash notes, which Avanish takes care of, and this is basically just a breeze through before the exams. Late night retina also Avanish takes care of, and this is also an excellent program for particularly retina surgeons. Surfing the anterior segment is taken care by Aarti Heda, and this is basically we discuss different types of anterior segment cases, including the oculoplasty ones. Like this one was on mucous membrane grafting and surface reconstruction, etc. We recently launched the legal cell as well. So all of these topics from consent, Consumer Protection Act, record keeping, indemnity, etc. Are being covered in these webinars. And all of these are available on the YouTube channel. We have a YOSI slides also. So you basically have a high quality comprehensive overview of a particular topic via a self-explanatory PowerPoint presentation in this. This is the journal club, so we do this monthly. Different articles are discussed, and this has a monthly mentor, a presenter, a moderator, research expert as well, and a couple of panelists who give the insight on this. So we have a YOSI fellowship desk. The email is this. Currently the email is having a little bit of problems. So for this, you can email me personally till that is fixed out. So basically we help guide them about fellowships and what is the options that they have after residency or during residency and their future as well. So you can just drop an email that I want help with this, and we connect you to a senior YO or somebody who's there, or even a senior mentor as well, who can help you with your career. We have a job portal as well. We have a residence network. Social culture also has done a couple of activities, like this is the one from the World Sight Day. What is the process of inclusion in these YOSI activities? We basically send out a form via our WhatsApp groups on the members groups, and basically you fill the form, and we try to include as many as possible. So why YOSI? So you want to become a part of one of the largest young ophthalmologists group of the world. You get access to YOSI publications, to the online repository, essential reading materials, and you participate in YOSI sessions, webinars, international, national, and state levels. You can submit video to our YouTube channel, which has got a lot of subscribers. Flash notes are there. You become eligible for the annual YOSI Young Ophthalmologist Award, and you get to network with young ophthalmologists at an international level as well. So basically, the three things you would say: you get a lot of opportunities, you get to connect with each other, and we help guide also, so that whatever problems that we've had in the past, you don't have to face them in the future. So we are having the AIS-YOSI forum on 8th and 9th April. I invite you all to this. This is an exclusive YOSI event in collaboration with the AIOS. We will also be having a pavilion at the AIOS as well. For that, we will be sending the forms out also. And we are also part of the organizing team of the second Global Young Ophthalmology Summit, which is going to happen from 19th to 21st January in Singapore. So come and be a part of YOSI. Thank you so much.
Karan sir, can you hear me, sir?
Yeah, I can hear you. Yeah.
I have just shared you the finalists in the first 3 sessions.
Okay.
Can you just, 4th session I meant to get the results. Can you just announce the first 3 sessions?
Oh, sure. Okay.
4th session we'll announce later or something.
So the session 1 finalists are Niranjana Balasubramaniam and Komal Patikar. Attachment case. For the session 2, the finalists are Dr. Aditya, Dr. Akshaya, Dr. Gajashri for the
I think there's a problem with the
Karan sir, I think there's a problem with your connection, sir. I think.
Sir, can you hear us, sir? Are you still with us, sir?
I think sir is not with us right now, sir.
Karan, Karan, can you hear us?
Am I audible?
Yeah, you're audible.
Yeah, now you're audible,
but,
sir.
we lost you in between.
Okay, in the meanwhile, I'll just congratulate all the participants. It was such a wonderful case presentation, and it was a close call for the judges. I think we got Dr. Karan back.
Am I audible right now?
Yes, sir, you're audible, sir.
Did my presentation come, or was there a glitch in the presentation?
The presentation was fine, sir. Completely fine.
Presentation was fine, Karan. Presentation was totally fine.
Yeah.
Maybe you can announce the list from the first.
Yeah, you can announce again. Karthikeyan or Prasanna, why don't you announce it? It's not an issue.
You do it, Karan. Finish it off. No.
Okay. I'll announce. Okay. So session 1 is Dr. Niranjana Balasubramanian and Komal Patikar for spontaneous DM attachment case. Session 2 is Dr. Aditya and Dr. Akshaya and Dr. Gajashri for asthma periocular swelling. Session 3 is Dr. Priyanka for the CMV retinitis case and Dr. Ishwarya.
Okay. We congratulate all the winners.
All the winners.
The session 4 will be announced soon. And yeah.
I think wonderful YOSI initiative also, Karan. I think for all the attendees attending today, they would have also seen it's not only a presentation, it's mostly an amalgamation of the work that has been done for the last 5 years by YOSI. And I think we all are trying to motivate people that what YOSI can actually offer to each and everyone. So today was just another presentation where we were able to offer case presentations, and I hope all the participants had a good learning. More than participating, each one of us had good learning, good interaction, and a good scientific discussion moreover.
It was an excellent.
Thank Karthik.
Yeah, please, Dr. Ravi, please go ahead.
No, I think we should thank Karthik, sir. Seriously, the amount of effort Karthik has put is tremendous, actually. Every day he used to call me He used to ask me how to do this, how to do things better. Every day he used to call, we used to brainstorm. All the images, this background you are seeing, he used to give ideas. He will just say, this is better, this is better. The amount of effort that Karthik has put is something tremendous. I think
that will go ahead in excellent work, Karthik. This will really go ahead in the future responsibilities that you will get. And, future, basically, you'll be able to guide other people now.
Yeah, I was constantly calling Dr. Sonal even at night, 1 o'clock. Whenever I get free, I'll message her and ask. And I was disturbing her again and again. And I was asking you, sir. I was asking Dr. Nilesh. And I was frequently contacting Dr. Pranesh, Dr. Prasanna, and Dr. Niranjan every 2 other days. See what can be done, what should we do. Every time I was.
Organizing isn't that easy. It takes a lot of effort, but once you do it, it becomes relatively easier then.
Thank you so much, sir, for giving
great effort. Great effort, guys.
Thank you, Karan, for being here. And we have just crossed half the well. Another half to cross tomorrow, I guess.
Okay, thank you, sir. Dr. Niranjan, are you here? Fine.
Niranjan, Karthik, you are not.
Yes, sir.
Say some words, something.
Yeah, you can also say.
Thank you, Karan sir. Thank you, Karthik sir, Prasanna sir, and Pranesh sir for helping us organize this. And it was wonderful to be a part of this initiative. And it was a wonderful presentation by all the presenters today. So like Karthik sir was saying, it must have been a very tough call for the judges to pick the top 2 and top 3. So looking forward to a more exciting session tomorrow as well.
Yeah.
Okay. Thank you so much for all the participants. I'll just announce.
We are posting the session 4 on the group, or we are announcing it?
It will take around 5 minutes. One of the judges have not gave the marks, so it's a close call again. It's a tie for second.
Tie, yeah.
Again, it's
total 10. Total 10.
Nalla irukku.
It's still a tie, sir. I am waiting for the third judge marks. Add it up and I just make it as a percentile and give. It's a very tough call, sir. So many
eight finalists now, Karthik. Totally.
Yeah,
now.
we have in session 1, Dr. Niranjana and Dr. Komal. In session 2, Dr. Aditya, Dr. Akshaya, and Dr. Gajasri. In session 3, Dr. Priyanka and Dr. Aishwarya. In session 4, it's a tie. As soon as I get it's between Dr. Mridula, Dr. Hemant, and one more person. As soon as I get it, I'll just announce the session 4. And it was a close call for Dr. Disha, Dr. Sindhuja, and Dr. Himani. It's just 0.5 marks difference. I was not able to make any decision, but to select only the top 2. Okay, fine, I will just announce in the WhatsApp group, I think.
Yeah, I think it will be better to do that.
Announce in WhatsApp.
Very late.
Okay, thank you.
We'll all meet tomorrow, and the participants who are not in the final also, please do come for the finals. And I think we'll learn more from the other set of judges who will be interacting in a much different way tomorrow. Yeah.
Okay, thank you, sir. We might finish the session.
Thank you, Karan. Thank you, Karan. Thank you, Karan.
Thank you, Karan sir. Thank you, Karan sir.
Thank you, Karan sir.
Thank you, Karan.
Romba nandri, Karan. Romba nandri.
No need for sir. Okay, Karan is fine.
Okay, right.
All of the same.
Yeah.
See you. Okay, bye-bye. Good night.